Good morning, everyone. We're sorry for the delay and sorry to keep you here. So we would like to tell you that we will start in the next 5 to 10 minutes, latest 10 minutes. The ministers are discussing and they will soon join us. Just to say welcome, bienvenue, and also Akwaba. In Cote d'Ivoire, we always like to use the word Akwaba. Akwaba also borrowed from Ghana, if I am right. So we will be welcoming every one of you. And we do hope that you enjoyed your trip to Cote d'Ivoire. So I wanted to say Gambia, sorry about it. I miss my little small country. So interpreters, are we ready to go? Are we good? Okay. So we are just waiting for the ministers to come. And as soon as they enter, we will start the meeting. I will also ready the technicians. Do we have the national anthem for Cote d'Ivoire? And do we have the AU anthem? We need both of them ready before we start the meeting when the ministers enter. That's thing. So I will give you a signal as to when do we observe the national anthem for Cote d'Ivoire and also the one for the AU. I will give you the signal. We also have colleagues also online. If we are, Samuel, do we have some people online? Just to tell them that now they can be close to their mics, and then we will soon start. And there's going to be a very interesting meeting, high-level meeting, and there'll be a lot of interactions. And we do hope you will enjoy this one-day Resco, our regional ministerial steering committee meeting, which is the first of its kind we're having in this region. And it is going to be an inaugural meeting, and we do hope that you will enjoy it. We also want to apologize to those who have challenges in the travel, but I'm not sure. But I think we all travel here safely without any challenge at the airport with regards to our tickets and with regards to, I think picking point was good. Everybody was picked on time. So we do hope to maintain that. And we do hope that you also enjoy your hotel rooms, and that when you came, you were received and you went to the rooms, and then you were given a very good bed. And I'm sure when you entered, you see the bed, you see about 6 pillows on the bed, and you were wondering, what am I going to do with these 6 pillows? And it's all part of for you to relax. So you are here to relax. I'm sure you must have forgotten about your laptop work or your work, carried forward work from home. You must have we want you to forget about work now and then enjoy the beautiful city of Abidjan. We have our system with us for translation for channel 1, that's French, channel 2, English, and channel 3, Portuguese. We have our Portuguese speakers here from Cabo Verde and Guinea-Bissau. And then we greet them, we say, bon dia. Now you are tuned. So we will improve our French. We will also improve our Portuguese as long as we are working in this region. And I want to be speaking French and Portuguese in the next coming 6 months, to take the mic and speak only French and Portuguese. That is my my mission, and I would really want to achieve this, so that I'll be not only bilingual, but at least I can be able to speak multiple languages. That's what I want to do. So we want to see if we have any challenges. Please let us know. We have our colleagues, John and then Adunola, who have been responsible for logistics. If you have any issues with logistics, let us know. But if you're also happy about logistics, let us also know, so that we give them the feedback. So yeah, we do hope that you enjoy the logistic arrangements from your home to here. I want to hear people to say yes or no. Did you enjoy your logistic arrangements from your home country to here? Was it enjoyable? The flight was good, smooth? No issues? No challenges at the airport? The traffic, yeah, that is part of Côte d'Ivoire. That's part of Abidjan. Monday to Friday, you're in Abidjan. Then tomorrow, everybody should leave a bit early, going to the airport. That's the advice we will always want to, because the traffic you cannot predict. It can be, but it's usually better in weekends, like especially Saturdays and Sundays. But other than that, the traffic is always a challenge in this country. But at least, if we are in Lagos, you will also cry. You know, the traffic in Lagos, I think, yeah. But at least, the driver we used when we are coming here, he knows this town very well. He used the shortcut, and we avoided the traffic. Maybe the driver you use does not know this town much and could not avoid the traffic. But overall, I think that's okay. So we are saying our logistic arrangements are highly satisfactory, if I am right. Can I say it's highly satisfactory? And those, yes. My colleague from Guinea-Conakry is saying yes. Mobenjarama. So I'm speaking to him in his local language, in Fulani. So I can speak Fulani anywhere I go. So I can be in Guinea-Conakry and solve my problems. And if you talk about Mandingo, or those for Bamara or Mandinga Mori, we can also, yeah, we speak the same language, we understand. So yeah, so it's easy. Our chair, welcome. He's our able chairperson of our RITAC. He's also around. We will also want to welcome, this is his show. We'll welcome him. And then, yeah, we will do the introduction if all the ministers are seated. John, are we ready to go? Okay, let's receive our ministers, our honorable ministers of health. Let's kindly rise and then receive them. Let's give them a round of applause. Ministers will sit according to their flags. So, yeah, you may kindly get seated after the ministers are seated. Habibadu, thank you for the reminder. Thank you very much. And now we may kindly rise to witness the national anthem for Cote d'Ivoire, and then which is going to be followed by the national anthem of the AU. We can kindly rise for that, for the national anthem for both Cote d'Ivoire and the AU. Thank you. The AU. Thank you very much. You may kindly sit down, honorable ministers. Okay, good morning. Honorable ministers here present. And I want to start to recognize their presence by first starting with the Honorable Minister of Togo, Professor Chan Dam. We want to welcome you to Cote d'Ivoire. Kwabena Minta Akando, Minister of Health of Ghana. Dr. Pedro Tipote, Minister of Health of Guinea-Bissau. Also want to welcome you. Dr. Hamed Lamin Samate, Honorable Minister of Health of the Gambia. And Mariatu Kone Minister of Higher Education, Cote d'Ivoire. It's a mistake on the list. Okay. So I think that's what I've been given, but we'll correct it. So we want to recognize you, sir, as the Honorable Minister of Education for Cote d'Ivoire. We also want to recognize the presence of Kwadun Konan, the Director of Cabinet for Cote d'Ivoire, and also our host, who has invited all the ministers and all the partners and all colleagues who are working in the area of health in this region, in the name of Dr. Koku Alinon, who is the Regional Director for Western Africa region. Dr. Alinon, thank you and welcome. And also, this is your show, this is your event, and these are your guests. So on behalf of the entire region, we welcome them through you. And I'm happy that we are happy to receive the Honorable Ministers of Health for this region. We also want to recognize the presence of Dr. Mamadou Jarasuba, the Executive Director of WA-RCC in the Western Africa base in Abuja. We also want to recognize Dr. Hassan El-Haji Adakal. He's the Acting Executive Director of ECOWAS Regional Animal Center based in Bamako in Mali. Doctor, you're also welcome. We also want to recognize Dr. Akindele Olipekin Adebeyi is the president of the International Epidemiological Association. We also want to recognize you. It's also coming from the academia, because we are looking at health partners and academia. So they are also very important, and then work in the Anglophone countries. We also want to recognize the presence of Professor Segbun David, who is also a professor of health promotion at the University of Parakou Academia and the base in Benin, Cotonou, Benin. Prof, we're also welcoming you. We also want to recognize our permanent secretary of the Minister of Health of the Gambia, Dr. Yusufa Toure, who is also our chairperson of the RITAG, the Regional Technical Advisory Committee. He's the chair, and then he's now taking us on this one. So we want to recognize you, Mr. President. We also want to go back to the ministers. We have Professor Adama Jawara, who is the Minister of Higher Education. Prof, apologies for that error, and want to recognize you. It is good to have the Minister of Education within the Minister of Health Forum. This is a very important event, because this shows the collaboration between health and education. They cannot be separated. So we are happy to have the Minister of Education within our midst. And thank you for coming, and thank you for taking time out of your busy schedule. We also have Suma Musa, Doctor, who is the president of the West Africa Risk Communication and Community Engagement Network, based in Guinea-Conakry, and is currently coordinating all risk communication activities within the region. We also want to recognize you. We also want to recognize Professor Mamadou Samba, who is the Director General of Health in Cote d'Ivoire, who has been our host, who has been our support, who has been our foundation for Africa CDC in Cote d'Ivoire. We started our engagement first with him in 2023, and we have done a lot of work within this short period. So Professor Samba, thank you for all the support you have given to the Africa CDC. We also want to recognize Dr. Nanlup Ogbune, and who is also at RTSL, which I'm so also want to recognize you if you are around. We also want to recognize Lucien Manga, who is the WHO country representative for Cote d'Ivoire. We also want to recognize your presence. We also want to recognize Fatima Zana, the head of health at the GIZ. We also want to recognize you. We also want to recognize Seydou Dabire, who is also the protocol of WHO. We also want to recognize you. And also Mariama Stimbun, who's also WHO representative for UNICEF in Cote d'Ivoire. We also want to recognize you. And also Olumbun Negudud, that's the senior technical lead for UK Health Security Agency. We also want to recognize you. And also want to recognize all other protocols and also all the people who are here representing the ministries of health in their various countries. We want to recognize your presence. Each and every one of you, we want to recognize your presence. We want to thank you for coming. And then next will be, let me have the agenda. Can I have the agenda? Let's have the agenda. Let's have the agenda. Thanks. Now we will go straight to the program, and we will go straight to the opening ceremony. Before we go into the opening ceremony, the one who will lead us into the opening ceremony is someone who has been appointed around December to come and lead the Africa CDC Regional Coordination Center for Abuja, based for Western Africa, based in Abuja. He's someone with a wealth of experience, both at the government level and the Ministry of Health in Togo. He has handled senior positions in the Ministry of Health well before he's appointed as the mortality surveillance lead for Africa CDC at the continental level on a senior position. Well-experienced individual, and who has also been deployed to come and support Western Africa, which his country is part of that particular region. And he did not reject it. He accepted it in good faith because he's coming to support his own region. He came with an ambition that I want to see that the Africa CDC Regional Coordination Center for Western Africa is fully operationalized. And this operationalization depends on having the human resource capacity and so on. So based on that, he has also laid out some plans and suggestions to move the agenda forward. So this other person is no other person other than Dr. Koku Alinon. He's a regional director. Come and give his opening remarks. Dr. Koku, welcome.
Thank you so much, Modu. But I want to make sure everyone has the message in his language. So I want to see with the interpretation service, which channel is French, which one is English, which one is Portuguese. Can you direct us so everyone get the message? Please, interpretation service. One is French.
One is French.
Okay.
And 2 is English.
Yeah.
And 3 is Portuguese.
All right.
Donc le 1 c'est français, le 2 c'est anglais et le 3 est portugais.
OK. Et donc, est-ce que vous pouvez vous assurer que, messieurs les ministres, ont la langue nécessaire pour ce message? Il faut vous assurer si le message passe. Oui. So, are we good now? Okay. OK. Merci beaucoup. Comme nous sommes en Côte d'Ivoire, le pays hôte, dont la langue française est la langue officielle, nous allons ouvrir cette session avec le français. Et donc, Excellences, euh, Monsieur le ministre de l'Éducation nationale, l'enseignement supérieur, Prof. Adama Diawa, Monsieur le ministre Prof. Daré Thiem du Togo, le ministre de la Santé du Togo, Monsieur le ministre Kwabena Minta, ministre de la Santé du Ghana, Monsieur le ministre Pedro Pipot, ministre de la Santé de la Guinée-Bissau, Dr. Amadou Lamine, ministre de la Santé de la Gambie, Monsieur le directeur de cabinet, Kwadjo Kona, Dr. Mamadou Diarasuba, directeur exécutif de ECOWAS, qui s'occupe de la surveillance au niveau de l'Afrique de l'Ouest, Dr. Hassan Eladji, qui est le directeur exécutif par intérim de la structure qui s'occupe des questions d'animal de la CEDEAO, Dr. Akedile Adebie, président international de l'épidémiologie du terrain, l'association sur l'épidémiologie du terrain qui est au niveau de l'université, basée à Abuja, professeur Segbeignon, qui est professeur pour la promotion de la santé à l'université Parakou, qui vient aussi de l'université, et ça concorde parce que nous avons le ministre de l'Enseignement supérieur qui nous reçoit. Monsieur le Président du comité technique qui soutient la structure régionale de l'Ouest Afrique, qui est la structure de Africa CDC, chargée des questions de la santé, de protocole, et puis de la prévention, la politique de la santé au niveau de l'Afrique de l'Ouest. Monsieur Touré, Messieurs, Mesdames les partenaires, Messieurs les États membres, je vais nommer les 15 pays de l'Afrique de l'Ouest. Donc, quand nous parlons de l'Afrique de l'Ouest, c'est les 15 pays, sans exception. Mesdames et Messieurs les partenaires, Mesdames et Messieurs, honorables invités à vos rangs et grades respectifs, permettez-moi, au nom du directeur général de Africa CDC, son Excellence Dr. Jean Kassea, de vous souhaiter la bienvenue dans ce beau joyau que la Côte d'Ivoire a bien vouloir mettre à notre service pour accueillir cette première réunion inaugurale qui va soutenir l'Afrique de l'Ouest. Africa CDC pour l'Afrique de l'Ouest. Et donc, Africa CDC, c'est la structure qui s'occupe de la santé, mais qui émane directement de l'Union africaine, dont le siège est à Addis Abeba, en Éthiopie. Et donc, cette structure a un siège à Addis Abeba, mais a des structures régionales. Et donc, nous avons l'Afrique du Nord, dont l'Égypte abrite le siège pour la région du Nord. Nous avons Lusaka, en Zambie, qui abrite le siège pour la région du Sud. Nous avons Nairobi, qui abrite le siège régional pour l'Afrique de l'Est. Nous avons Gabon, qui abrite le siège régional à Libreville pour l'Afrique centrale. Et pour nous, l'Afrique de l'Ouest, c'est Abuja, le Nigeria, qui abrite ce siège. Et il faut dire, parmi les 5 régions, l'Afrique de l'Ouest est la plus grande région. Nous avons le plus grand nombre de pays et en matière de population, en matière d'espace, c'est la plus grande région. Nous sommes honorés d'être le premier directeur régional régulier qui prend fonction pour rendre fonctionnelle cette structure régionale. Je suis du Togo, mon nom c'est Koko Alino. Je voudrais avant tout remercier les honorables ministres, Excellences, Messieurs les ministres, qui, malgré vos charges, malgré votre agenda très chargé, avez choisi l'Afrique, notamment l'Afrique de l'Ouest, d'être présent pour discuter les questions de santé pour nous. Ceci est très important, spécialement en ces moments où les questions de financement de santé deviennent compliquées avec la diminution du financement qui vient de l'extérieur, du financement qui vient des partenaires. Il est vraiment très important à ce que nous nous organisions en tant qu'Afrique et précisément en tant qu'Afrique de l'Ouest pour réfléchir sur comment nous allons nous organiser pour que nous puissions gérer les questions de santé, notamment la question de préparation et de la réponse aux urgences de santé publique. L'Afrique de l'Ouest est endémique pour certaines maladies, notamment la maladie à virus Lassa. Nous avons eu Ebola en Afrique de l'Ouest. Actuellement, il y a le choléra qui sévit. Il y a la méningite qui est là avec sa bande. Ainsi, nous, en tant que ressortissants d'Afrique de l'Ouest, comment allons nous organiser pour que nous nous assurions que nos réalités, nos problèmes soient résolus dans notre contexte? C'est pour cela que Africa CDC a créé ces services régionaux. Messieurs les ministres, Mesdames et Messieurs les États membres, Messieurs les directeurs exécutifs, Mesdames et Messieurs les partenaires, chers participants, pendant 2 jours, de lundi à mardi, nous avons eu des discussions très fructueuses sur les questions techniques, sur comment les 15 pays peuvent s'organiser pour accompagner cette structure régionale sur les questions techniques. Et nous sommes honorés d'avoir le président de ce comité technique parmi nous, qui est la Gambie, et le vice-président, qui est le Cap-Vert. Et ces discussions nous ont permis d'avoir des résolutions que nous allons soumettre à votre appréciation, messieurs les ministres. Les partenaires ont été avec nous. L'idée avec les partenaires, c'est de voir comment nous pourrons nous organiser ensemble pour éviter la duplication d'efforts. Et pour le faire, nous avons matérialisé cela. Et je viens de le nommer, mon ami et frère qui est de la Côte d'Ivoire, qui gère le service régional, qui s'occupe de la surveillance et du contrôle de maladies. Notre réunion a été organisée ensemble avec cette structure, qui est une structure de la CEDEAO. Et nous sommes arrivés à un plan commun. Nous avons présenté ce plan commun. Et Africa CDC, nous avons aussi des plans communs avec l'UNICEF et avec l'OMS. D'abord, nous voulons démontrer qu'au niveau sous-régional, nous sommes unis derrière les mêmes objectifs. Nous servons les mêmes pays. Nous voulons nous assurer que nous ne dispersons pas nos énergies. Et donc, messieurs les ministres, notre travail, c'est de coordonner. Africa CDC, nous ne cherchons pas à voir qui fait quoi ou on va prendre quoi de qui. Notre préoccupation, c'est de savoir qui fait quoi dans quel domaine. Quelles sont les insuffisances, comment nous pourrons coordonner ce domaine et comment nous pouvons travailler avec les partenaires pour combler l'insuffisance. Donc, tout le monde a sa place. Actuellement, l'Afrique de l'Ouest est très vaste. Et je viens de mentionner les épidémies qui sont en cours. Et donc, tout le monde a sa place. Nous allons viser la coordination et nous allons viser à tout faire pour éviter les duplications d'efforts. Monsieur le ministre, cette journée serait concentrée précisément au lancement du premier bureau qui va servir de conseil d'administration pour Africa CDC de la région ouest africaine. Nous souhaitons que ces élections se passent dans une convivialité. Et moi, d'ores et déjà, je vous promets que je serai à votre service. Ce bureau qui va être constitué par les ministres va servir à nous donner les directives sur ce qu'il faut faire et ce qu'il ne faut pas faire. Notre objectif, en tant qu'Union africaine, c'est de servir nos États membres. C'est pour cela que nous partons toujours d'un état des lieux. Nous essayons de voir quels sont les besoins au niveau de chaque pays et comment, ensemble avec les pays, nous pouvons répondre aux besoins. Nous n'allons pas concevoir des programmes pour venir imposer aux États membres. À chaque fois, nous allons nous adresser aux États membres pour qu'ils nous disent leurs besoins réels et comment ensemble on peut s'organiser pour les gérer. Et c'est pour ça que ce bureau est vraiment très important, parce que ce bureau va servir de fondation pour nos activités. C'est avec cet espoir que la première réunion qui se tient à Abidjan, ici en Côte d'Ivoire, se passe dans une convivialité, que je voudrais, avant de clôturer, une fois encore remercier les États membres pour leur apport, pour leur soutien au quotidien, aux côtés de Africa CDC. Je voudrais remercier également les partenaires qui ont été toujours à nos côtés. Et je voudrais remercier la Côte d'Ivoire pour avoir accepté d'abriter cette première réunion. Nous savons que nous sommes en période de Ramadan. Ce n'est pas facile, même aujourd'hui, c'est un jour férié en Côte d'Ivoire, mais nous avons vu les officiels parmi nous. Le ministre de l'Enseignement supérieur est parmi nous. Le directeur de cabinet est parmi nous. Le directeur général de la santé est parmi nous. Et autant d'autres. Ça témoigne de la solidarité. Ça témoigne de l'engagement que la Côte d'Ivoire a pour soutenir cette structure régionale. Ainsi, je voudrais très sincèrement vous remercier en tant que pays pour avoir traduit ce mot Akwaba. Dès que tu sors de l'avion et que tu veux descendre, tu vois Akwaba. Akwaba, ce n'est pas seulement un mot, c'est la réalité. Et vous venez de le traduire en réalité. Monsieur le ministre, toutes nos reconnaissances pour cela. Mesdames et messieurs les ministres, je voudrais terminer en disant merci. Ça nous tient vraiment à cœur que vous ayez laissé, même la réunion qui se tient actuellement à Paris sur la nutrition. Des ministres ont été invités, mais ils ont dit non. Nous venons en Côte d'Ivoire pour Africa CDC, parce que Africa CDC, c'est le nôtre. Et nous le voyons déjà avec ce qui se passe ailleurs, que nous devons prendre nos destins en main. Nous allons le discuter, les questions de financement au cours des séances qui vont arriver, qui démontrent qu'on a intérêt à s'occuper de nous en tant qu'Africains et de nous en tant que ressortissants de l'Afrique de l'Ouest. Ainsi, permettez-moi de vous remercier une fois encore et de vous dire encore Akwaba.
Thank you very much, Dr. Koko. We can have a round of applause for him again for that wonderful statement. Again, I want to reiterate just to recognize again our host, Professor Adama Jawara, who is the Minister of Higher Education, and also the Dr. Charles Kofi. We visited him many times in his office. He's also the permanent secretary, or they call them here Director of Cabinet. But we visited also him in his office several times. So thank you for coming, Dr. Kofi. We also want to recognize the member states, all of you, all the 15 member states that are present here. We really want to recognize and thank you for coming. I now have the honor to invite our brother, Dr. Momodu Jarasuba, who is the Executive Director for ECOWAS RCSDC based in Abuja. Doctor, welcome.
Excellences, Messieurs les ministres, Monsieur le ministre, professeur Adama Diawara, cher maître, ministre de l'Enseignement supérieur et de la Recherche scientifique, Monsieur le professeur Ntien Daré, ministre de la Santé du Togo, Excellence, Monsieur le ministre Wabena Menta Ando, ministre de la Santé du Ghana, Dr Pedro Tipote, ministre de la Santé de la Guinée-Bissau, Dr Amadou Lamine Samalek, ministre de la Santé de la Gambie, les collaborateurs du ministre ici présents, le docteur Akacha, directeur de cabinet, et professeur Samba Mamadou, mesdames et messieurs les représentants des ministres des États membres de la CEDEAO, ici présents dans la salle, mesdames et messieurs les ambassadeurs et chefs d'institutions internationales, monsieur, mon ami et frère, docteur Kokou, le directeur du Centre de coordination régionale pour l'Afrique de l'Ouest de l'Afrique CDC, mesdames et messieurs, chers membres des délégations ici présents, mesdames et messieurs les partenaires techniques et financiers, l'OMS, l'UNICEF, USHCA, USCDC, GIZ, AMP, Resolve to Save Life, etc. Chers amis de la presse, mesdames et messieurs, chers collègues, distingués invités, tout protocole observé. C'est avec un immense honneur et une satisfaction que je m'adresse à vous aujourd'hui au nom du directeur général de l'OAS, le docteur Aïssi Melchior, en ma qualité de directeur exécutif du Centre régional de surveillance et de contrôle des maladies de la CEDEAO. Nous sommes ici, Monsieur le ministre, dans ce beau pays, particulièrement dans cette belle ville d'Abidjan, pour la réunion inaugurale du comité de pilotage ministériel régional de CDC Afrique pour l'Afrique de l'Ouest. Cette réunion marque une fois de plus l'opportunité de faire le point de la coopération en matière de sécurité sanitaire dans notre sous-région ouest africaine. Permettez-moi d'exprimer ma gratitude à travers Dr Kokou au directeur général de Africa CDC pour nous avoir associés intimement à cette activité. Excellences, messieurs les ministres, mesdames et messieurs, l'Afrique de l'Ouest continue de faire face à des menaces sanitaires complexes et récurrentes. On peut citer entre autres les épidémies émergentes et réémergentes, les défis posés par les maladies non transmissibles, les risques liés aux crises humanitaires et climatiques. Et face à ces menaces, la résilience de nos systèmes de santé est plus que jamais cruciale. C'est la raison pour laquelle le Centre régional de surveillance et de contrôle des maladies de la CEDEAO, qui est le bras opérationnel de l'OAS dans la lutte contre les épidémies et urgences sanitaires, a entrepris des consultations avec le CDC Afrique et d'autres partenaires régionaux en vue d'intensifier les efforts pour bâtir une architecture de santé publique solide, réactive et durable. C'est dans ce contexte que nous avons développé un plan conjoint régional, lequel plan a été adopté durant la deuxième réunion du comité consultatif technique tenue ici même à Abidjan les 24 et 25 mars 2025, avec quelques actions significatives, dont l'harmonisation des systèmes de surveillance épidémiologique à l'échelle régionale pour renforcer l'interopérabilité des données des bases de données et de partage d'informations en temps réel entre nos pays. Et aussi à renforcer les autres interventions de préparation et de réponse en insistant sur la coopération multisectorielle et la coordination sous-régionale entre le Centre régional de surveillance et contrôle des maladies de la CEDEAO et le Centre régional de coordination RCC de Africa CDC en Afrique de l'Ouest. Excellences, Messieurs les ministres, Mesdames et Messieurs, l'Afrique de l'Ouest a fait des avancées remarquables, mais il reste encore beaucoup à faire. Nous avons donc la responsabilité collective d'assurer un leadership fort et visionnaire pour renforcer la sécurité sanitaire dans notre sous-région. Nous ne devons donc plus être une zone de réaction, mais nous devons être une zone où la promotion de la santé, la prévention, la préparation proactive et coordonnée, intégrée, doit occuper la plus grosse partie de nos interventions. Pour cela, nous devons soutenir les approches multisectorielles de coopération, de coordination et d'intégration sous-régionale face aux crises sanitaires qui ne cessent de nous surprendre. Nous devons veiller à ce que nos mécanismes de financement ne soient plus dépendants de l'extérieur. Nous vivons actuellement une crise avec ce que nous savons, avec l'arrêt des financements extérieurs. Mais qu'ils soient de plus en plus intégrés dans nos politiques nationales et de façon durable. C'est pourquoi l'Organisation ouest africaine de santé, à travers le Centre régional de surveillance et de contrôle des maladies, dans un esprit de solidarité et d'intégration régionale, réaffirme son engagement et poursuivra ses efforts pour promouvoir, accompagner et soutenir les innovations et les actions qui transformeront de façon durable nos systèmes de santé. Excellences, Messieurs les ministres, Mesdames et Messieurs, je vous remercie et je remercie vos gouvernements respectifs pour votre attention et vos engagements en faveur d'un avenir plus sûr pour la santé publique en Afrique de l'Ouest. Vive la coopération régionale, vive la résilience de nos systèmes de santé, vive l'Afrique, une Afrique en bonne santé. Je dirais simplement, dans les 3 langues de la CEDEAO, obrigado, merci et thank you. C'est ça.
Thank you very much, Dr. Mamoudou Jarasuba, the Executive Director of WA-RCC. We will just do a short statement. We want the mics, the moving mics. Do we have them on the table? So that we give chance to our colleagues. We just need one moving mic, which we give chance to our colleagues from GIZ to give a short statement, and followed by a result to save life. Also, we'll give a short statement. And also we have the UK Health Security also. The 3 of them will give their statements where they are seated. So colleagues online, we want to welcome you. The sessions, as I said, have started. So if you want to make any contributions, you are most welcome. So we start with GIZ. GIZ colleagues, where are they? And they just take the mic to them and then they give their GIZ. Are we around? GIZ. Okay. Fatima, so the mic is yours.
Distinguished honorable ministers, honorable permanent secretaries, directors of the various departments, public health institutes. Okay. Thank you. Directors of the various public health institutes, the regional director of Africa CDC, executive director, RCSDC, executive director of the Regional Animal Health Center. I would like to stand on existing protocols so that I do not miss anyone. So distinguished colleagues, ladies and gentlemen, on behalf of GIZ, I would like to thank Africa CDC for inviting us to this very critical and important event. GIZ globally has been a strong partner in the formation and establishment of Africa CDC and in ensuring that it is being able to deliver on its mandate in supporting and promoting the health of the citizens of Africa. The Regional Center for West Africa, recently arriving in Abuja, has become a key partner in ensuring that the health of the region, but also of the continent, is safeguarded. As the regional directors have said, health security has become even more critical with the recent events that we have witnessed. And as partners, we have a responsibility to ensure that the support that we provide is sustainable in ensuring that Africa can promote and protect the health of its citizens. So as a committed partner to the mandate, I would like to once again wish the Technical Advisory Committee the best of luck and also reinstate our commitment to supporting the advisory committee in delivering on its mandate, but also to plead with the steering committee as we go into the deliberations to provide the support that this very important body is here to deliberate on, ensuring that Africa CDC can deliver on the mandate that has been established on. So thank you so much once again for inviting us to this very important event, and we look forward to observing and participating over the course of the day. Thank you.
Thank you very much, Fatima. You can also give the mic to Resolve to Save Life, our colleague. You can just stand there and then so that they see you. UK Health Security, you can also be on standby.
Good morning, the honorable ministers and permanent secretary, and all the member states represented and different organizations. I will stand on existing protocol. I bring you greetings from the CEO and President of Resolve to Save Lives, Dr. Tom Frieden. To say that as a partner, we've been working across the globe and we've enjoyed strong partnership and collaboration, both with Africa CDC and the ECOWAS CDC. The first 2 days of this working week, we were part of the RETAC, and a lot of the outcomes and recommendations that came out there shows and demonstrates the importance of solidarity, demonstrates the coordination that is taking place, which will go a long way to strengthening the capabilities of our region to be able to adequately address health emergency issues as they would definitely come. We recognize as a partner and we commit ourselves to continue to work with the different agencies and institutions to ensure that they're able to deliver on their mandates. First, I'm Nigerian, but first we're Africans and we also are West Africans particularly. And so we have a patriotic responsibility to ensure that we safeguard the health of our own continent and of our own region. So I want to implore and plead with the Resco that this will be, I'm looking forward to the inauguration. We all are. We hope that the outcomes of this inaugural committee, which is a laudable initiative, will bring the desired results. So thank you for having us. I recognize Dr. Alina for inviting us and the Honorable Director General for Africa CDC for also recognizing the importance of partnerships, and with centered on solidarity, we join you all, and we wish all of us a fruitful deliberation. Thank you very much.
Thank you very much. Now we move to UK's health security. My own sister.
From the Gambia. Good morning, all, and I bring greetings from my country lead, Dr. Olushola Aruna. My name is Olubumi Negedu Momo, and first I want to recognize the honorable ministers and also the regional director, Dr. Kuku, and also the executive director of the RCSDC ECOWAS, Dr. Mahmoudou, and all distinguished colleagues that are sitting, the member countries of the ECOWAS, and also partners. I just want to say this is a very great event, and want to say thank you to the African CDC for recognizing the UK health security. We've actually been partnering also from the Central, that's from the Addis Ababa, working with the team in the Ethiopia and also eastern parts. So UK health security has been part of this Africa CDC supporting the region from onset. So I want to also mention that the UK Health Security, which is a UK-8 funded project for technical assistance to ensure compliance to international health regulations and also global health security. We've actually have that mandate to support the national public health institutions for strengthening them to have the capability for detection and response to public health threats. So we've been also, we are in many countries and across from West Africa also to Ethiopia, to Zambia, Asian, and also working with WAU, which we have a MOU with them. So the regional support has been part of our key objective to ensure that we strengthen the region, especially West Africa. And this has been on the front burner for us. So I would say we are so happy to be here and seeing this, the RITAC second advisory committee meeting and also being part of the Resco also. I think it's a great privilege for us to also being able to provide contributions, being able to support and being able to strengthen the region. First, I've had so much, and I know that we all know here that the disease has no border. Once it starts from one country, it spreads to another country. So we can't say it does not concern me. It's one country or the other. So we are here to actually build the region. It's going to be a strong collaboration and coordination. And I'm happy I can actually feel that strength being part of this meeting for Monday. And I want to wish all of us a fruitful steering committee meeting, and also the inauguration of this to happen. So thank you so much for the opportunity, and wishing everybody a very fruitful deliberations. Thank you.
Thank you very much. Before I call on the chair, I just want to recognize our colleagues from the member state, Dr. Taya S. Moore, who is the one on my middle right, in one side, and the right side. He's the Assistant Minister of Health for the government of Liberia. So I want to welcome you. We also want to recognize Dr. Momodou Ba, who is also the Councillor of the Ministère de la Santé, the Republic of Guinea. You also have Dr. Maria Dalu Lima, who is from Cabo Verde, who has been with us throughout the RITAC meeting. And then we also have Dr. Dabire Dembele, is the Councillor de Technique at the Ministère de la Santé de Burkina Faso. So he's also around. So thank you very much, colleagues. Thank you for coming. We are really happy that you are around. I now move on to the RITAC chair to give a remark. RITAC chair, you can kindly come and give a short remark.
Honorable Minister of Higher Education and Scientific Research, Côte d'Ivoire, Honorable Ministers of the Western Africa region, I mean Honorable Ministers of Health from the Western Africa region, and also representatives from the Ministries of Health of the Western Africa region, distinguished partners of Africa CDC, Director General CDC, Western Africa region, senior government officials of Côte d'Ivoire, members of RITAC, Western Africa region, distinguished colleagues, ladies and gentlemen. The RITAC feels honored to make this remark before this August gathering of health ministers and other distinguished personalities. Today, we gather with a shared purpose and commitment, and we are determined to fortify our Western Africa region for enhanced preparedness and with a bid to elevate our health outcomes. Our resolve and resilience have always been tested, have already been tested in the recent past, and we had been awakened to the reality of a predicament that kept our heart in our mouth for a long time. Our inherent vulnerabilities as a continent had been exposed. Today, there is urgent need for sustained investment, and there is also the imperative for a coordinated regional response to emerging and re-emerging diseases. Let us not overlook our achievements, but that notwithstanding, we must acknowledge the challenges that lie ahead. We are richly diverse, and our public health challenges are unique to us as a region. And therefore, we must together build tailored solutions that are unique to us. We shall focus on enhancing our disease surveillance systems, strengthening our laboratory capabilities, improving our vaccination coverages, among other things. We must not also forget the urgency of addressing the non-communicable diseases and ensuring a resounding mental health support for our young population and women. We must improve our collaboration with our global health partners. Together, we can leverage our collective strengths and resources to build a healthier, more resilient future for Africa. We must not abandon our spirit of unity and cooperation that define us as Africans, for diseases know no boundaries or colors. Our singular resolve today as Africans is to overcome the barriers that stand in our way of achieving quality universal health coverage. Today and going forward, we shall engage openly and share and explore for a richer and rewarding health systems. Today's generation and generations to come in Africa deserve a stronger, healthier Africa. An Africa that will no longer have its heart in the mouth because a pandemic is glaring at us. I thank you all for your kind attention.
Thank you very much, Retired Chair, who is also my boss at the Minister of Health in Gambia. So happy to have you here. We also want to recognize Dr. Colonel Ide Adamu Habibatu from the Minister of Health in Niger. We also want to recognize you. He's also the focal point for National Public Health Institute in Niger. And I've been informed that the director is going to visit your country very soon. So we hope that they will also really enjoy the visit, Director. I'm sure you'll enjoy Niger. Thank you. We also want to recognize the presence of Mamadou Lamine Lee, who is the technical advisor number 2 at the Minister of Health in Senegal. We also want to recognize him. I also want to recognize the Director of Public Health in Nigeria, my brother on the right. We also want to recognize you, who is also the Director of Public Health in Nigeria, sitting just right on the right. Now we move on to the agenda again. We now have statement from or welcoming remarks by the Professor Adama Jawara, the Minister of Higher Education of the Republic of Cote d'Ivoire, to give this statement on behalf of the Minister of Health. You're most welcome. There's one representing, you know, when the Minister of Health is not there, so you want to step it in.
Excellences, Messieurs les ministres de la Santé des pays frères, en l'occurrence la Gambie, le Ghana, la Guinée-Bissau et le Togo. Mesdames et Messieurs les représentants des ministres de la Santé des autres pays de la CEDEAO, disons de l'Afrique de l'Ouest, Monsieur le directeur régional de Africa CDC, région de l'Afrique de l'Ouest, Mesdames et Messieurs les représentants des organisations internationales, distingués invités, Monsieur le directeur du cabinet de mon cher frère et collègue Demba Pierre, chers amis de la presse. C'est avec un immense honneur et une grande fierté que je prends la parole aujourd'hui à l'occasion de cette réunion ministérielle qui est le comité de pilotage organisé par Africa CDC de la région Afrique de l'Ouest, ici en Côte d'Ivoire. Je voudrais noter que c'est la première réunion de ce comité ministériel. Permettez-moi d'adresser, au nom du ministre de la Santé, de l'Hygiène publique et de la couverture maladie universelle, mon frère M. Pierre Demba, donc du gouvernement ivoirien et de son peuple, nos plus chaleureuses salutations à chacun d'entre vous et le traditionnel Akwaba en terre ivoirienne. Votre présence ici témoigne de l'engagement collectif et indéfectible de nos nations à œuvrer pour la santé et le bien-être de nos populations. Le ministre Demba est actuellement en mission hors du pays avec les vice-présidents et il m'a alors demandé de le représenter à ce comité de pilotage. Je crois que tout à l'heure on en a parlé. La santé est un pilier fondamental du développement durable et de la prospérité de notre continent. Nous sommes réunis aujourd'hui pour réaffirmer notre engagement commun à bâtir des systèmes de santé résilients, capables de répondre aux défis sanitaires d'aujourd'hui et de demain. La pandémie de COVID-19 nous a enseigné de précieuses leçons. Elle a révélé nos vulnérabilités, mais aussi notre capacité d'adaptation et d'innovation, et elle a mis en lumière la force de la coopération et de la solidarité africaine. Grâce aux efforts conjoints de nos gouvernements, de l'Union africaine et d'institutions telles qu'Africa CDC, nous avons pu renforcer notre réponse face aux crises sanitaires. Cependant, de nombreux défis demeurent, notamment la lutte contre les maladies infectieuses émergentes et réémergentes, l'amélioration des infrastructures sanitaires, l'accès équitable aux soins et aux vaccins, le financement durable, je dirais même pérenne de la santé, la préparation et la réponse aux futures crises sanitaires. Excellences, Messieurs les ministres, distingués invités, l'émergence et la réémergence des menaces sanitaires, qu'il s'agisse de pandémies, d'épidémies ou de catastrophes naturelles, nous rappellent l'urgence d'améliorer notre capacité collective de préparation et de réponse. C'est dans cette perspective que le règlement sanitaire international RSI 2005 prend toute son importance. Cet instrument juridique essentiel permet de 1. Prévenir, détecter et répondre efficacement aux événements de santé publique. 2. Assurer la sécurité sanitaire mondiale tout en préservant les échanges et les économies de nos nations. Je tiens à saluer le rôle essentiel joué par Africa CDC dans la coordination des efforts de santé publique sur le continent. Votre leadership, votre expertise et votre engagement ont été déterminants dans notre réponse aux crises sanitaires récentes et ils seront tout aussi cruciaux pour l'avenir. Africa CDC accompagne nos États membres, particulièrement les 15 pays de l'Afrique de l'Ouest, dans la mise en œuvre effective du RSI à travers le renforcement des capacités nationales en matière de prévention et de surveillance des maladies, l'harmonisation des stratégies de réponse aux urgences sanitaires, la gestion efficace des risques sanitaires, le développement et l'amélioration des laboratoires de référence en Afrique. Ces actions sont essentielles pour garantir une réponse rapide et efficace aux futures crises sanitaires et pour bâtir une Afrique plus résiliente et autonome en matière de santé publique. Excellences, Messieurs les ministres, distingués invités, notre mission est claire. Renforcer nos systèmes de santé pour un avenir plus sûr, plus sain et plus prospère pour l'Afrique de l'Ouest. Nous devons passer d'une approche réactive à une approche proactive, cela a été dit tout à l'heure. Nous devons investir dès aujourd'hui dans la prévention et la préparation. Nous devons consolider nos partenariats stratégiques et renforcer la coopération régionale. Nous disposons du talent, des ressources et de la volonté politique pour assurer la sécurité sanitaire de nos populations. Ensemble, en consolidant nos efforts, nous pouvons bâtir un continent résilient, mieux préparé aux urgences sanitaires et garantir un avenir plus sûr pour tous. Sur ces mots, je déclare ouverte cette première réunion ministérielle du comité de pilotage de Africa CDC de la région Afrique de l'Ouest et je souhaite à chacun des échanges fructueux et des décisions porteuses d'espoir et de progrès pour notre région. Je vous remercie.
Thank you so much, Honorable. Let's give him a round of applause for speaking on behalf of the Minister of Health. We are moving gradually towards the end of this session. The next speaker will be introduced by our Regional Director, Dr. Koku, who will introduce our next speaker. So Dr. Koku, you are kindly welcome to introduce our next speaker who will do the opening statement for this meeting. Thank you.
Thank you so much, Modu. Honorable Ministers, Excellencies, our Director General, Dr. Jack Asea, did everything to be here with us. And you can notice the embassy, Côte d'Ivoire embassy from Addis, they sent one of their officers to support us with this. All the reservation was made. Yesterday night, something happened and he could not be with us. So he requests me first to apologize for this. So our Chief of Staff, Dr. Bilgisu Balde, she is from Guinea-Conakry. Yeah. So Dr. Bilgisu is the one nominated to represent DG for this open remark. So allowed me to introduce Dr. Balde, who is one of us. This is West Africa. So, Dr. Balde, if you are online, kindly, the floor is yours.
Thank you very much, Dr. Koko. Can you all hear me okay?
Yes, we can hear you. Go ahead, please.
Perfect. And then I'm going to switch to French, given that we are in Ivory Coast, Côte d'Ivoire. Excellence, Monsieur le ministre de l'Éducation supérieure, représentant du ministre de la Santé de la République de Côte d'Ivoire. Honorable ministre de la Santé des États membres de l'Afrique de l'Ouest. Monsieur le directeur exécutif de ECOWAS, chers collègues de Africa CDC, distingués représentants des gouvernements, Mesdames et Messieurs les représentants des médias, distingués invités, Mesdames et Messieurs, dans vos rangs et grades confondus. Permettez-moi avant tout propos de vous transmettre les salutations chaleureuses de notre directeur général, son Excellence Dr. Jean Kaseya, et de partager son profond regret de ne pas pouvoir se joindre à vous aujourd'hui. En effet, il était prévu qu'il puisse se joindre en personne, comme l'a mentionné mon collègue Dr. Koko. Cependant, un impératif de dernière minute lié aux urgences sanitaires continentales l'ont empêché de se joindre à vous. Il m'a néanmoins confié l'honneur, à ma qualité de directrice de cabinet et de directrice du bureau exécutif de Africa CDC, de porter sa voix et de transmettre en son nom sa profonde gratitude pour votre engagement, mais aussi de partager quelques mots de discours. Excellence, honorables ministres, Mesdames et Messieurs, Africa CDC a été établie en tant qu'institution technique spécialisée de l'Union africaine pour servir les États membres dans la prévention, le contrôle des maladies, afin de protéger la santé des populations africaines. Cette mission s'incarne à travers le renforcement des capacités des professionnels de santé publique, l'assistance technique au pays avec l'utilisation rigoureuse des données pour orienter des réponses efficaces aux urgences de santé publique, mais aussi de bâtir des systèmes de santé résilients. Excellence, honorable ministre, pour atteindre ce mandat, nous sommes conscients que les États membres et partenaires que vous êtes sont essentiels, mais surtout que cet objectif commun que nous nous sommes fixés ne pourrait être accompli sans un partenariat solide, mais aussi dans un esprit de coordination régionale et de collaboration multisectorielle. C'est dans cette vision que Africa CDC a mis en place les régions, les centres de coordination régionaux à travers l'Afrique que Dr. Koko a mentionné dans les différents pays. Ces centres ont pour mandat de mettre en œuvre le plan stratégique d'Africa CDC au niveau régional, mais aussi de soutenir les États membres dans leurs besoins spécifiques dans les pays, de renforcer les synergies avec les institutions régionales et partenaires techniques à travers le continent. Chère Excellence, j'aimerais profiter de cette opportunité aussi pour saluer avec gratitude la République fédérale du Nigeria pour sa disponibilité, pour sa générosité, mais aussi pour son leadership. Grâce à l'accord de siège qu'on a signé avec Africa CDC et le gouvernement du Nigeria en mai 2024, ils ont pu mettre à disposition un bâtiment pour servir de siège au centre régional, ce qui a permis d'avoir une fondation très, très solide, mais aussi pour l'opérationnalisation du centre régional. Je tiens également à féliciter les États membres de la région pour leur engagement continu, tel qu'en témoigne votre présence ici aujourd'hui et votre participation active aux différentes initiatives régionales depuis l'établissement de ce centre. Ce dynamisme illustre l'importance que revêt le centre pour assurer une interface fluide entre le siège d'Africa CDC et les 15 États membres de l'Union africaine de la région est-africaine. Permettez-moi, Vos Excellences et Mesdames et Messieurs, au nom du Directeur général, de vous affirmer de notre engagement et détermination à mettre en œuvre la décision des chefs d'État et des gouvernements portant sur l'établissement des centres de coordination régionaux avec toutes les ressources nécessaires et les capacités pour remplir pleinement leur rôle de soutien auprès de vous. En effet, ce centre n'est pas simplement un bâtiment, mais cela symbolise notre coopération, mais aussi notre volonté commune à atteindre les objectifs de sauvegarde sanitaire de l'Afrique. C'est donc avec une grande fierté que nous assistons aujourd'hui à l'inauguration officielle de ce comité ministériel régional de pilotage de l'Afrique de l'Ouest, réunissant les ministres de santé des 15 États membres Et il s'agit également d'un moment clé pour nous, pour promouvoir la coopération multisectorielle, la coordination interétatique et l'alignement des priorités en matière de prévention, de préparation et de réponse aux urgences sanitaires. Je ne saurais m'attarder, je sais on a eu une matinée assez chargée, mais j'aimerais avant de conclure, Excellences et Mesdames et Messieurs, lancer un appel à l'engagement collectif des membres du comité de Resco afin qu'ils puissent accompagner et apporter leur orientation stratégique au centre régional dans sa mission pour assurer une Afrique de l'Ouest plus sûre, plus résiliente, mais avec une population saine. Enfin, je tiens à remercier sincèrement le gouvernement et le peuple de la République de Côte d'Ivoire, à travers son Excellence, Monsieur le ministre de la Santé, d'avoir bien accepté d'accueillir la toute première réunion inaugurale de ce comité régional. C'est donc un grand honneur pour moi, au nom de son Excellence, Dr. Jean Kasséa, de marquer ce moment solennel et de saluer l'inauguration officielle du comité régional. Je vous remercie pour votre attention.
Merci beaucoup, Dr. Baldé, pour ces mots très forts qui mettent l'accent sur la sécurité sanitaire, qui mettent l'accent sur le soutien des États membres à l'action de Africa CDC et qui reconnaît l'effort que les États membres fournissent et qui rétablit Africa CDC dans son rôle. Et donc, ce comité est là pour donner les directives, pour montrer le chemin à suivre. Et le directeur général espère de nous que nous puissions suivre des directives qui répondent à nos réalités en tant qu'Afrique de l'Ouest. Merci beaucoup, Dr. Baldé. Ainsi, prend fin cette première séance et je vais passer la parole à mon collègue Modou pour nous situer sur les étapes à suivre. Merci.
Thank you very much, Dr. Koku. Now we have come to the end of the opening ceremony. Now we'll be going out for the group photo, which will be done outside. I'm sure my colleagues are preparing the ground so that the ministers will move and then the other colleagues will follow. And then we have the group photo. Then we can go for break. And then this break will take about 15 to 20 minutes. And then we come back, we continue with the session. So I will retire my role here for now. And then I'll come back again in the afternoon. But my other colleagues will pick up from here. Thank you very much, and thank you all. And then apologies if your names are not mentioned at the beginning. So sincere apologies. But yeah, we are together in this. And I want to thank all of you. Honorable ministers, maybe we'll give you a signal. They are just preparing. You want to have photos with them, you can have individual photos with them whilst we are preparing the ground. The ministers are here. Yeah, so from here then, are they ready? Yeah, they'll be going downstairs. I think Samuel is saying, let me hold on for now, yeah. So when they are ready, they will call. They are preparing the ground. We go downstairs, they'll be the last to come, yeah, they'll be the last to come. Yeah, so colleagues can go down and then the ministers will follow. And then followed, partners can also follow. And member states also will follow after the partners. Then the ministers will follow the member states. Yeah. Colleagues will be going out for a group photo, and then we will continue with break up to 20 minutes, and then we will, reconvene again after the break. So colleagues online, you may kindly just take a walk or you want to stretch, and then you follow us after 25 minutes at most. Thank you. Okay, thank you.
Cryptocurrency investing, when approached with a long-term perspective, Cryptocurrency investing, when approached with a long-term perspective, can be a powerful way to build wealth while supporting an emerging technology that has the potential to reshape modern society. However, it requires a disciplined strategy, sensible allocation of resources, and a deep understanding of the market's potential and risks. This guide focuses on building a sustainable and well-informed cryptocurrency investment strategy for long-term success, emphasizing moderate spending of disposable income over the years. The foundation of long-term crypto investing starts with a clear belief in the transformative potential of blockchain technology and digital assets. Cryptocurrencies like Bitcoin have already disrupted traditional finance by offering a decentralized peer-to-peer system of value transfer. Ethereum has expanded Cryptocurrency investing, when approached with a long-term perspective, can be a powerful way to build wealth while supporting an emerging technology that has the
Good
potential
morning.
to reshape modern society.
Good morning. I want to draw your attention back to the meeting. We should be starting the next 2 minutes. We are only waiting for the few honorable ministers to come and join us, and then we start. Hello. Good morning. Good morning. Let's take our seats, please. Hello, let's take our seats. Thank you so much. Honorable ministers, distinguished ladies and gentlemen, allow me to stand on the protocols and take us through this session. My name is Elfas Ojambo. I am the Partnership Officer for Africa CDC in the West Africa region. And to take us through this, we have an agenda that will guide us through. And I would like to start by telling you a story. As a young man, when I grew up in Kenya, I had this dream of coming to West Africa. It was a dream. And you know what I wanted to come to study? Witchcraft. That was my dream, that I would come to West Africa to study witchcraft. But then many years down the line, I found myself in Ghana to study, but not witchcraft, but to study economics. So that dream came true. The only part that didn't come through was the witchcraft part of it. But I found myself in West Africa, and from there since, West Africa has always been my second home. And it is indeed an honor to moderate this particular session, honorable ministers. We have some expected objectives for this particular meeting. And I request my colleague Sami to share with us that. So as we are waiting for that, maybe that was not part of the witchcraft. Yeah. So Summit, please, next slide. So Honorable Ministers, we have 3 objectives for this particular meeting. One is to bring ministers of health and public health technicians, technical experts, foster collaboration and knowledge sharing. The second objective is to establish a strong governance framework to support the work of West Africa Regional Collaborating Centers mission to strengthen public health emergency preparedness across the region. And the third objective is to officially launch the Resco. And I think all of us came here because of that. We want to launch our first Resco, and it's something that we are looking forward to. What do we expect as an outcome of this particular meeting? We expect ministers of health and public health technical experts to be successfully brought together to foster collaboration and knowledge exchange. We also expect as an outcome a governance framework to guide the support West African RCC and support West African RCC's mission to strengthen public health, emergency preparedness and response across the region. So establishing that governance structure is key. And thirdly, to officially launch the Resco. So those 3 expected outcomes at the end of this particular day, if we don't achieve that, please tell us. That's our expectation. There is something that you saw there. I think if some of you just go back, there's a building that you are seeing there. There was a building in the first page, which is our headquarters. And there's a building that we are seeing here, which the regional director did mention that the government, the federal government of Nigeria ceded this building to us to be our regional collaborating center. It is still work in progress, and we believe that we will be able to move finally to that particular building so that then we can have a place we call home. And all of you, maybe one of the Resco meetings could also be held there, because it's quite a big facility that if renovated, then we'll have a big home, one of the biggest RCCs in Africa CDC. I would like to call upon my colleague, Dr. Lainka Stephen, to come and make his brief presentation about the new public health order and the Africa CDC vision for safeguarding Africa's health agenda. This is a brief presentation. So
okay, thank you. Good morning once again, honorable ministers, the regional directors, and the executive directors. I want to stand on the existing protocol to save time. So I'll be doing a brief presentation on the public health order for Africa CDC and our vision for safeguarding Africa health security agenda. Okay. So Africa CDC was established in January 2016 by the Assembly decision of the Ordinary Assembly of the Head of States and Governments, and it was officially launched in January 2017. And the main purpose is to support the member states' public health initiatives and strengthen the public health initiative and the capacity to detect, to prevent and control, and also respond quickly and effectively to disease threats across the continent. Africa CDC's mandate, as known, we are an autonomous health institution of the African Union and established to support public health initiatives of member states and strengthen the capacity of their public health institutions to detect, prevent, control, and respond quickly and effectively to the threat of diseases. Our vision is to have a safer, healthier, integrated, and prosperous Africa, in which member states can effectively, efficiently prevent disease transmission, implement surveillance and detection, and always be prepared to respond effectively to health threats and outbreak. And how do we intend to get this done? Our mission is to strengthen the capacity, capability, and partnerships of Africa public health institutions to do the same as mentioned above. Now, the new public health order was a call to action by the African Union head of states and governments and head of delegation that participated at the special side events during the sideline of the 77th session of the United Nations General Assembly. And the new public health order has about 5 spokes through which different interventions are meant to be strengthened across the continent. The first one is to strengthen public health initiatives. And this is being carried out through the National Public Health and Research Institutes, local universities, strengthening of emergency operation centers and genomic sequencing capabilities across the continent. And the second is to expand local manufacturing. For instance, just about 1% to 2% of all the vaccines that we use in Africa are being manufactured within. And the plan is that by year 2040, 40 to 60% of these vaccines can be manufactured in Africa. To also strengthen diagnostic therapeutics and other medical supplies. The next is to strengthen respective and action-oriented partnership. This involves long-term engagements, alignments of priorities, and also to ensure that African member states are on the driver's seat. Next, we want to increase domestic health financing, and I'm happy that some of our ministers will be guiding us later today on how we can effectively do this. Despite the Abuja Declaration and the Africa Epidemic Funds, we notice that the funds that is available for disease prevention on the continent is still less than what is expected. And lastly, strengthening of public health workforce is one of the fifth priorities of the new public health order. This involves the training of field epidemiologists, the intermediates, the frontliner, and also the advanced, and strengthening of community health workers, ensuring that they are properly trained, they are also deployed to areas that are necessary. As I speak, we are having training of also AVOC volunteers at our HQ in Addis Ababa, which is to empower people to strengthen the health system in the member states by serving as a gap for health workforce. And also we have several training for public health leaders. We have a ministerial education for leadership training for ministers and other form of trainings for other senior staff of the Ministry of Health in the member states. Now, the Africa CDC Regional Coordinating Center is to help the Africa CDC in ensuring success in the carrying out the items and activities that I mentioned earlier. So the RCCs is to support the member states and to create Africa CDC without walls, so that at the point of need, the RCCs are closer to the member states than the headquarters. So with the support from the RCCs, we want to ensure that rather than serving the member state from a centralized location that is distant, we can ensure that we are close to the people, we know their problem, and quickly we can start intervention as at when due. So the Regional Coordinating Center, in executing its function or its strategic work plan, will harness public health assets in each region. And the coordination and support of the RCC is to ultimately bring into reality Africa CDC without walls, as I mentioned previously. Now, these are the core functions of the RCCs. And the first is to foster coordination collaboration and integration among African Union member states, regional economic communities, and public health stakeholders. We are also we are also tasked with the mapping, strengthening, and networking of public health assets to harness existing capacities and capabilities for advancing public health impacts in the region. We facilitate knowledge exchange and sharing of health information in a timely manner. Implementation of the Africa CDC strategic plan within the region is of utmost priorities to us. These are some of the programs that have been carried out or that we are still working on at the West Africa Regional Coordinating Center. Under the laboratory, we support RISNet, biosafety and biosecurity. We have the Africa Pathogen Genomics Initiatives, through which a lot of items and equipment have been donated to all the member states in the region. And a lot of people have been trained through our capacity building efforts. We have our disease control and prevention and health promotion initiatives as well, several surveillance initiatives, EPR. We strengthen the National Public Health Institutes, and we have several other programs, including the Regional Knowledge Hub, Health Information Exchange, Partnership for Africa Vaccine Manufacturing, Infection Prevention and Control, and also the Saving Lives and Livelihoods initiatives. I would like to mention a few of these milestones, of these programs that we have implemented, just to keep us abreast of the milestones. Now, a joint planning meeting was conducted with the regional economic communities in West Africa, that's ECOWAS Center for Surveillance and Disease Control, in August 2024. And we have also been part of the regional workshop on event-based surveillance for Africa CDC technical officers and event-based surveillance officers from all the member states in the region. In addition to this, our pathogen genomics initiatives, as I mentioned, have led to donation of equipment in millions of dollars, training and capacity building of health workforce, especially those in the laboratory sector. So the PGI survey on Mpox testing and sequencing capacities have also been done. I would like to remind you that when the COVID-19 outbreak started in Africa in February 2020, in the region, we had only 2 laboratories with the capacity to sequence COVID-19 specimen. But at the moment, we've ensured that this sequencing can be done in all the member states, and even the staff in the member states, their capacity have been built and strengthened to stand in the gap as at when needed. We also conducted site visit for diagnostic assets evaluation that was done in Nigeria and Ghana, technical support on diagnostics and sequencing at the IPD Senegal, Dakar, installation and training of sequencer at Mali, Burkina Faso, and some other countries as well. Now, included in our pathogen genomics initiative is strengthening integrated genomic surveillance. This took place in Abidjan, here in Côte d'Ivoire, with support from the Robert Koch Institute's capacity building initiatives. The West Africa RCC also facilitated installation at the Central Public Health Reference Lab in Sierra Leone. The same happened in Nigeria. We installed diagnostic and public health laboratory equipment. Likewise, we handed over Starlink equipment to the Nigeria Center for Disease and Control in Nigeria to ensure that data from genomic sequencing can be uploaded in real time. Analysis of Mpox in Central and Western Africa are also timely reported to the headquarters through our pathogen genomics initiatives. We have also had programs on mortality surveillance. We supported Burkina Faso, Ghana, and Republic of Mali in the development and finalization of National Strategic Action Plan for the implementation of mortality surveillance in the 3 countries. Under our Emergency Preparedness and Response Program, we currently completed heavy metal poisoning assessments in Nigeria. 2 states had heavy metal poisoning. The cause of the poisoning were not really known. So we supported Nigeria with the heavy metal poisoning research. And likewise, the dynamic risk assessment of cholera was also carried out in Nigeria through Africa CDC. We also supported public health assessment of disease outbreak in Burkina Faso in June to July 2024. We supported about 10 member states to develop pandemic fund proposals including several multi-country, though we were glad that 2 of our countries that we supported were able to get the fund as well. The RCC also supported 4 member states, Nigeria, Cote d'Ivoire, Liberia, and Guinea, to develop response action plans in alignment to MPOC's continental plan. In addition to this, we contributed to the strengthening of the National Public Health Institutes. We supported the development of roadmap to accelerate National Public Health Institute establishments in West Africa. This helped us to create a comprehensive roadmap that outlines strategic steps that helped us in expediting the establishments of the National Public Health Institutes. In Nigeria, Liberia, and Burkina Faso National Public Health Institute have been designated as Center of Excellence based on their capacity and provision of mentorship to other MPHI, not only limited to West African states, but across the continent. We have sponsored staffs from other National Public Health Institutes to learn from Nigeria, Liberia, and Burkina Faso. And we also facilitate peer-to-peer learning exchange program. We coordinated peer-to-peer learning program to facilitate knowledge sharing and best practices between Eswatini, Kenya, and Liberia National Public Health Institutes. We supported development of the National Public Health Institute Centers of Excellence. Assessment of work plan was also done, and we assisted in developing detailed work plan for assessing potential center of excellence within the National Public Health Institute to enhance capacity and capabilities. We supported the Center of Excellence to have joint activity planning meeting. This was done in Liberia in 2024. And likewise, we had the same in Ouagadougou in August 2024. We supported 7 member states with the procurement of public health emergency operation center equipment. The member states are Ghana, Guinea-Bissau, Benin, and Burkina Faso as well. Under our supply chain management, through funds donated by MasterCard Foundation, we supported the Republic of Benin with cold chain equipment worth 233,000 USD. And likewise, Africa CDC supported the Republic of Burkina Faso with similar cold chain equipment in tune of more than about $2.5 million. And Africa CDC also supported the Republic of Cote d'Ivoire with cold chain equipment that is in the tune of $1.2 million. Africa CDC also supported the Republic of Guinea-Bissau with cold chain equipment worth 592,000. We supported the Republic of Liberia with cold chain equipment in the tune of 384,000 thereabouts. And likewise, the Republic of Mali was supported with equipment worth 609,000 USD. And likewise, Africa CDC, we supported Nigeria with cold chain equipment in the tune of 3.5 million USD. Africa CDC also supported the Republic of Sierra Leone with cold chain equipment worth 542,000 USD. The picture above on the right panel was during the handing over of cold chain equipment in Liberia, and the one below was my humble self when I represented Africa CDC in donating the cold chain equipment to Cote d'Ivoire, the same country. I think the director was okay. Good. So I want to thank you and appreciate you for your attention.
Thank you so much.
Muito obrigada. Obrigada. Eu não sei se tem perguntas. Será que tem?
Okay. Okay, so it seems like we have no question for the time being. May I call upon our next presenter, who is also from the Secretariat, and she'll be making a presentation regarding our governance structure as Africa CDC, West Africa Regional Coordinating Center. Shoma Danwafo, please come forward.
Thank you, Dr. Elfas. Honorable Ministers, representatives of member states, distinguished ladies and gentlemen. My name is Choma Danwafo, and I will be presenting to you the terms of reference for the RETAC. So this presentation will set the stage for the inauguration and also the election of the leadership of the RETAC. To provide an oversight into what the key mandate of the Resco, I keep saying RETAC, apologies, of the Resco is, and what is expected from the Resco, as well as their terms of reference. So my colleague, Dr. Lesome, has already alluded to the slide in terms of the key responsibilities of the RCC and why the RCC came into reality, which is to have an Africa CDC that is decentralized, owing to the fact that the HQ will not be able to coordinate the support to the 55 member states. So the 5 regions had to establish the centers of excellence so as to be closer to the member states, have that direct oversight, and also help to strengthen their capability to ensure early prevention, detection, and response to public health emergencies. So for the governing structure, we have first the Regional Steering Committee, which is a Resco, which is why we are here for the inauguration, and whose main mandate is to provide a strategic guidance to the RCC to ensure operationalization and the smooth operations of the RCC to be able to achieve its key deliverables. The second is the RETAC. We just concluded the second meeting 2 days ago. And the role of the RETAC is to provide technical guidance to the secretariat. And finally, we have the RCC that serves as the secretariat for the regional governance structure, and of which the regional director serves as the secretary. So here again is our building ceded to us by the Nigerian government following the signing of the Memorandum of Understanding in May. And hopefully we should be able to get this renovated and fully functional. So this is one of what we will be discussing as to how to take this to the next level. So in terms of the composition of the steering committee, the number and the composition of the Resco shall be determined by the respective region. At a minimum, the Resco should be composed first of the ministers of health from all the member states in the region, which for us is the 15 member states in the region. And the second is a representative from the African Union organs hosted in the region. And we also have representatives from the regional economic communities, WAHO, the WA-RCC, and we also have representatives from the academia and civil society. And the Resco would have representative from the animal health, the environmental, and the private sector, so that we can have a One Health approach, as well as any other experts that may be deemed necessary to join the Resco. For the key mandate and functions of the Resco, first, the Resco shall provide a strategic guidance and oversight and support to the RCC secretariat on public health initiatives and interventions, which will be primarily on the regional priorities, but then also taking into consideration what the member state priorities are. And also the Resco will review proposals that will be submitted by the RETAC through the RCC acting as the secretary before submission to the secretariat for the governing council, for the governing board consideration. So later today, we'll have the chair of the RETAC present the communique from the second RETAC meeting for the consideration of the Resco. The third is to monitor and guide the implementation of the RCC programmatic plan in addressing regional health priorities. And finally, the Resco will also support the RCC Secretariat in resource mobilization and advocacy efforts. So this is really a key priority for us, given the dwindling funds. And we want to see how we can be more innovative in ensuring that for our region, we have funds to be able to respond to health emergencies. For the leadership and election of Resco, Resco shall have a chairperson, a vice chairperson, the secretary, which will be the RCC director, and members with technical expertise as deemed necessary. And the Resco chair will be elected by the Resco member, apologies, with a 50+ consensus. And the ministers, the representative from REX and AU organs are organized as voting members. And in the event of a change in the person representing a member state, the new person shall continue to be the member of the steering committee representing the member state. So if there's a change in the minister, the new minister who takes over then continues to as the member of the Resco. For tenureship, the tenure of the Resco chairperson and the vice shall be for 2 years, and the tenure is non-renewable. And to also ensure representativeness, the executive members shall serve on a rotation basis across the 15 member states. We'll look at the duties of the chairperson. The chairperson shall first and foremost convene the board meetings, and the chairperson shall also preside over the proceedings of the board meetings. He or she shall open and close the meetings, submit for approval the records of the meetings, guide the meetings discussions, submit for a vote matters under discussion, and announce the results of the votes taken, as well as rule on points of order. The chairperson shall also ensure order and decorum during meeting proceedings. The absence of the chairperson, or in the case of a vacancy, the vice chair shall act as the chairperson. The RCC in the region will serve as a secretariat, and the regional director shall serve as the secretary of the steering committee. For quorum and decision-making procedures, the quorum for a meeting for the committee shall be by a simple majority of the voting members. And whenever possible, decision of the committee shall be adopted by consensus. And in the event that consensus cannot be reached, decisions shall be taken by votes on the basis of simple majority of the members that are present. And representative of member states that are subject to sanction under Article 23 and 30 of the Constitutive Act shall not have a right to vote in accordance with the rules of the procedure of the Assembly. For conduct of sessions, the committee shall convene at least one physical meeting a year for an ordinary meeting. The committee may meet in extraordinary sessions at the request of the RCC, the chair, or any member state on approval of 2/3 of the voting members. In the event that the Minister of Health is unable to participate in the Resco meeting, then he or she may delegate the deputy, the permanent secretary, or any other senior official to represent he or she. For meeting agenda, the secretariat shall communicate the agenda of the meeting as well as the working documents to members at least 14 days before the committee meeting. The provisional agenda for each meeting of the committee shall be considered for adoption at the opening of the meeting. Minutes of the meeting shall be distributed 14 days after the meeting, and minutes shall be considered for adoption at the opening of the subsequent meeting. For enumeration, the role of the member of the steering committee is not enumerated. But then members of the committee are entitled to reimbursement of their travel expenses and a daily subsistence allowance, TSA, when attending physical steering committee meetings. And the local office of the Africa CDC shall be represented at all committee meetings. For the amendments to the TORs that have just been outlined, the TOR of this committee may be amended by the simple majority of the voting members. So if there are points that we do not agree with, that can go into voting, but then that's when the chair and chairperson, vice chair has been nominated, and we can then go into discussion as how some of the TOR can be amended. And any amendment to this TOR shall enter into force upon adoption, except for the composition of the committee and the terms of office of the chair and the vice chair. For language of communication, the working language of the committee shall be the AU official language for the region, which for us is English, French, and Portuguese. And when necessary and appropriate, we'll have translations provided, which we always have in our meetings. So I will conclude by hoping that this TOR served as a foundation to guide the Resco committees to be able to achieve its mandate, drive impactful public health outcome in the region, strengthen regional coordination and security, as well as foster effective collaboration among member states. I thank you.
Thank you so much, Chioma, for that presentation. I think it's also a learning experience for us, honorable ministers. There were some of these things, you set up this organization called Africa CDC, and at the same time, you set up an organization called WAHO. It's like a family where you have two children, 2 sons or 2 daughters. They're all your children, right? And therefore, every now and then you need to ensure that they work together. There's no fighting in between those. And when you see them working together, you are happy. And when you sit down to see the results like that was being shared here by Dr. Olesome, it was more or less like telling you, I bought you a shirt, Dad, or Mom, I bought you this dress, I bought you this. But that doesn't mean that that's the only thing you're depending on. You also have some other things that are happening. So we really appreciate the support that Africa CDC is giving to our member states. And we were told for the last 2 days, we had the Regional Technical Advisory Committee meeting. And in that particular meeting, which was quite interesting, we also had resolutions. And I want to call upon the chair of the RITAC, Dr. Yusufa Torre.
Okay,
Yes.
Ask if we have questions. Or you want us to bring them at the end?
Okay, I'll give you an opportunity to ask questions. Please, sorry, please go ahead.
I think Chioma, for that presentation. I just wanted to find out about a few things. Now, it was said the meetings can be convened in the presence of the chair and the deputy chair. If both are not available, what happens? Can the membership amongst themselves select an interim chair or someone to oversee the conduct of a meeting in such circumstances? Would that be possible? The second one is with regards to the composition, with the description of some of the members towards the end. To me, probably we need more clarity Otherwise, it is going to be ambiguous when we get the actual people, where it lumped up private sector, I think. And then if we could have that slide again, and the animal health and all those, does it mean a representative from each of those, or are they going to be lumped together? And now, having known the number of member states, I was thinking that it is important for us to now put the cap, counting those ones for clarity sake, that we are going to have 20 members specifically, or 21 or 22, because otherwise then coming back to the interpretation, it could be a challenge. Now, this, I believe, we want some further clarity. And also the minutes, availability of the minutes of the meeting. It said 14 days. Now, does it mean within 14 days, or it has to be 14 days on the dot? Would it rather be not later than 14 days? Statements like that, because if it says 14 days, or does it have to be 14 days on the dot, and so on. Now, with regards to the mandate to change the TOR, I was also wondering, just asking, the components that are not changeable by Resco, who has the mandate to change those? Thank you.
Thank you so much, Honorable Minister. As Chioma comes, we also have a legal representative from our HQ, and both of them will be able to respond to the issues which are quite pertinent that you've raised. So Chioma, please.
Thank you, Honorable Minister, for the question. So this is more of a legal document, so I will have my colleague from the legal office supporting the response. And then also to mention that this TOR is part of the RCC framework, which is still a draft and work in progress. We are trying to still harmonize it across board so as to address all the needs of the 5 regions, taking into consideration that some regions are yet to be operational, and that's the northern region. So in terms of the clarity on leadership of the meeting, so if we do not have the chair or the vice chair present, I believe the chair can nominate a member of the RETAC to chair the meeting, but then I'll leave that to Brave to answer or provide more context on that. For membership of Resco, what we did for RETAC was to identify the maximum members that will be part of the RETAC, and that will also be part of the deliberations that will happen once the election is done and the inauguration has been done. So we will decide as to the maximum number for Resco. But then the 15 member states will be represented by a member, which will be the Honorable Minister for Health. And if there is a meeting he or she cannot attend, then he or she can designate either the Deputy Minister, the Permanent Secretary, or a senior representative from the Ministry of Health. In terms of the availability of minutes, like you likely mentioned, yes, the minutes should be available not later than 14 days after the meeting to all the members of the Resco to review, make their inputs, and then the Secretariat will finalize and share with the members of the Resco. So maybe Brave, we can add one.
All right. Thank you very much, honorable ministers and distinguished ladies and gentlemen. My name is Brave Hanunka. I'm from the legal team at Africa CDC based in Addis Ababa. My colleague Chioma has done a good job responding to the questions. So one thing maybe, which maybe most of us already know, of course, we're guided by statute as Africa CDC, and then it takes us to the draft framework of operations that we're trying to do for the RCC. That still requires to be validated by the RETAC, and of course also approved and validated by the Resco. So it's still a draft document. But in terms of how Africa CDC is structured, especially when you got all the way to the governing board, what is important, and the statute allows that the rules of procedure can actually, once the Resco and RETAC is constituted, Africa CDC is not, the statute does not restrict us to follow the framework of operations and TORs as if they are cast in stone. But actually the statute allows that once the RETAC and Resco are constituted, then they are able to also develop the rules of procedure that will help to guide. So those rules of procedure will actually be developed by RETAC and Resco, so that then once they are finalized, they also guide some of the questions that the Honorable Minister asked. So it means that the rules of procedure can help us to understand the 14 days, what 14 days means, and also even around composition. So we hope that we can also move into ensuring that our rules of procedure are also in place, even as Resco. Thank you. Yes. Oh, okay. The question on the mandate to change the terms of reference. So again, like I mentioned, the rules of procedure again can guide as to what process we can take to change the terms of reference. They are not really cast in stone. They are really part of the draft framework of operations. So again, the idea of having the Resco RETAC is to again assist the Secretariat in terms of how what can be added from experience, from practical experience. So then this document is not really a Secretariat document. The terms of reference are really part of the governance structure. And that's the reason why having a Resco is really important. I don't know, Honorable Minister, if that answers the question. Thank you.
Do we still have some questions? Additional questions, comments, clarifications? Okay. So may I use this opportunity to invite our chair of the RETAC, Dr. Yusufa Toure, to come and share with us or to indulge us in what was discussed and resolved at the RETAC that just ended on Tuesday. Dr. Yusufa, please.
Thank you very much, Chair. This document is titled Resolution of the Second Africa CDC Western Africa Regional Technical Advisory Committee, RETAC meeting, 24th to 25th March 2025, Abidjan, Cote d'Ivoire. The preamble. The Africa CDC Western Region Coordinating Center convened its second Regional Technical Advisory Committee, RETAC meeting in Abidjan, Cote d'Ivoire, from the 24th to the 25th March 2025. The meeting brought together RETAC members, partners, stakeholders, and member states in West Africa. The discussion highlighted the role of RETAC in strengthening collaboration and coordination with member states to address health inequities and improve health security in the region. Partners present at the meeting include UNICEF, ECOWAS, RCSDEC, ECOWAS Regional Center for Animal Health, Resolve to Save Lives, International Epidemiological Association, ECOWAS RCCE Network, GIZ, UK Health Security Agency, and representatives of ministries of health in Western Africa region. The meeting concluded with a renewed commitment from all participants to advance the Africa CDC agenda in the region, and a resolution as follows. Resolutions. Considering the discussions and deliberations, we, the RITAC members, unanimously adopted the following resolutions. Part 1, that is for the RITAC members, facilitate cross-learning among RITAC members through joint meetings organized by Africa CDC Western Africa Region Coordinating Center. Identify priority areas of focus in implementing the activities agreed upon at the second statutory RITAC meeting. Provide guidance on adopting the Western Africa Regional Coordinating Center's strategic plan to ensure regional priority implementation. Ensure constant follow-up actions from the adopted report of the first, that is the 2024 RITAC meeting, are executed effectively. Part 2 is on the Africa CDC West Africa, Regional Coordinating Center. We, the RITAC members, urge the Africa CDC WA-RCC to adopt the following. Finalize and implement the 2025 Regional Joint Work Plan with ECOWAS RCSDC for effective regional implementation. Mobilize domestic resources for the implementation of strategic regional priorities in the region. Conduct the second round of stakeholders and partners meetings to increase regional collaboration and partnership. Strengthen coordination between Western RCC and ECOWAS RCSDC through joint initiatives in the region. Plan and support the implementation of peer-to-peer learning among RITAC members to increase their understanding of the work of Africa CDC in the region. Establish robust monitoring and evaluation frameworks to assess gaps and challenges in implementing health initiatives in the region and provide the needed solutions. Part 3 is on the Ministers of Health of the region. We, the RITAC members, urge the Ministers of Health to strengthen Africa CDC's collaboration with member states by formalizing the nomination of the Africa CDC focal point in the 15 member states. This will ensure smooth coordination and implementation of Africa CDC activities in the member states. Call for signing the Data Sharing Agreement, DSA, between Africa CDC and the 15 member states to facilitate data harmonization and adequate reporting in the region. Advocate for allocating adequate financial resources for health initiatives in the 15 member states by exploring innovative financing mechanisms such as taxes on tobacco products to support public health initiatives. The sustainability of these initiatives is critical to address the implementation of the Abuja target and Ouagadougou declarations on adequate health financing by governments is essential. Acknowledging the critical role of the Western Africa Regional Technical Advisory Committee, emphasize the need to develop targeted interventions that address the region's unique health challenges. Call for an increased investment in research to understand the regional health dynamics, especially the impact of health emergencies. Stress the importance of fostering multi-sectoral collaborations and partnerships among governments, partners, NGOs, academia, and the private sector to enhance the effectiveness in implementing health initiatives in the region. Conclusion. We express contentment with the second Africa CDC Western Africa Regional Technical Advisory Committee, RETAC, meeting by recognizing its significant role in providing an invaluable platform for comprehensive and inclusive discussions on how to move the Africa CDC agenda in the region through collaboration and partnership. We extend our heartfelt appreciation to the organizers, Africa CDC Regional Coordinating Center, partners, and the Ministry of Health of the Republic of Cote d'Ivoire, for their unwavering support in facilitating this critical second statutory meeting. We are committed to advancing these resolutions and call upon governments, the Africa CDC, the regional economic communities, RECs, and all stakeholders to implement the proposed actions, ensuring their alignment with national and regional health development agendas. The meeting acknowledges the ongoing challenges, including health financing, and encourages significant strides to be made through collaborative efforts, innovative approaches, and a strong commitment to health inequity. Together, we can create healthier and more equitable access to health services in the Western Africa region. Presented in Abuja, Cote d'Ivoire, presented in Abidjan, Cote d'Ivoire, 27th March 2025. Thank you.
Thank you, RETAC Chair. I think let's appreciate him. Let's applaud again. Honorable Ministers, that's an outcome of 2 days of intense consultation that happened Monday and Tuesday. And remember also that this was the second RETAC. The first one happened in Abuja, Nigeria last year. Then this being the second one, we believe that we will be able to build on. So every day we are putting not just one brick, maybe 2 bricks at a time. And we believe that the next RETAC will produce more results. And we'll also at the same time ensure that we don't just produce resolutions, but we also work towards implementation of the same. I want also just to inform you that during this RETAC, our dear friends from the ECOWAS Regional Center for Surveillance were part and parcel of this. And I think that's why the ED is here, and he's part and parcel of us. It is one thing that West Africa, we are now together, we are looking at things and believing that togetherness is the only way we can be able to go to address some of the challenges that we are having. If we decide to divide and say this is Africa CDC space and this is ECOWAS space, then we will not be able to go far. The problems that we are facing do not understand those things. I remember the other day I was joking with a colleague and saying that there are no French diseases. Neither do we have Anglophone diseases. Disease is a disease, right? So whatever we are talking about, language should not be a barrier, but we should all resolve to ensure that we address that for which we set our institution to address. I don't know if there is any comment, reaction. Yes, Honorable Minister.
Again, Dr. Jambo, and we thank the chair for that presentation, and we thank all of you for the hard work. Getting these documents together, getting the information is not an easy task, especially getting a consensus of what comes out is even a more difficult task. But I was wondering if we have it in other languages as well, because I just saw the English version. So if it's not in the other languages, usually the tradition is they are distributed at the same time, so that the other members can also benefit from it. But the second thing is, now we are very happy that you spoke about collaboration, collaborating with the Africa Centers for Disease Control. But I think another emphasis is also collaboration between the countries. Our countries do not collaborate much. We don't interact much. Some countries have more expertise in one area than the other, and others also have more in one than the other. We think we should collaborate to complement each other's efforts and to know what's happening in one country and the other, so that we can typically support each other. Because we want to work as a family, but if we do not know each other's problems, we cannot support each other. Now, that is one of the reasons why some of us are very happy for the reason that Africa CDC came into being, in the sense that we could have a marketplace where ideas are brought on board, where the problems of countries are brought on board, and the solutions that can be offered by other countries are also brought on board. We think Africa CDC should form that link. But we need to work on that, because we are not collaborating much. Even when it comes to sharing human resources. Gambia, probably we want so much of a particular, specialist. They are maybe in another country, we don't know. Even the collaboration with regards to supplies. We might have industry. We are talking about local manufacturing. Now, we might have industries in Cote d'Ivoire that could support Gambia. We might have in Nigeria, Ghana, that could support Gambia. But rather, Gambia will be struggling to get it from outside Africa, because we don't know what is in these countries, and they don't know what our needs are. So I think we need to focus on that, so that we can look inwards to support local industry within. Otherwise, these meetings are just going to be talk shows. We have to actualize, and we hope RITAC will be able to, being the technical advisory unit, will be able to guide us in all these areas when it comes to human health, animal health, all these areas. Now, finally, I want to also find out what the procedure is. There is a resolution. Then what happens to the resolution? Does the resolution have to be adopted by the Resco? Because you presented it to us as part of what you want your result for us to do. And then if it is going to be adopted by Resco, is it now or after the Resco has been constituted? These are my questions. Thank you.
Thank you so much, Honorable Minister. I'm looking at my RD to come and respond to some of the questions that you've raised. But I know that in terms of the resolutions, adoption of the resolutions, that is usually done once we put this structure in place. And so once the RESCO has been established and inaugurated, then now they can be able to say that we listen to that, then we adopt it. I stand guided. But in terms of the other issues that you've raised, my regional director can be able to respond to some of those. Dr. Koku.
Thank you so much, Alphonse. Excellency, this is a draft that needs improvement. So all of these comments will be integrated. So we want to adopt this by the end with the integration from the Resco members. And you mentioned something which is very critical, collaboration between our member states. When we are talking about local manufacturing, we can not have all member states doing this. So if Nigeria is doing this, how do we support Nigeria? So how do we leave space for Nigeria so other member states can benefit from what is going on in Nigeria. We need market space when we are talking about local manufacturing, because you can do this and you don't have people to consume this, it will not work. So we will integrate this collaboration among member states, even try to see if we can put in place a kind of conference for member states to share experience, a kind of community of practice, a 3-day or 4-day meeting where we invite a Minister of Health, but also Minister of Higher Education, because when we are talking about health, we are also talking about education. All the FLTP, advanced, all of them is about education. So we see how we can leverage all those priority. So let us have Secretariat get input. We will have the French version because this is a draft. That's why we didn't translate this to French. But at the end, as soon as we adopt this, we will come up with the French version and the Portuguese version. Thank you so much, Honorable Minister.
Thank you, Honorable Minister. Thank you, RD. I can see that Honorable Minister has one more question.
I know we just want to, I'm delaying everyone, but RD, probably it's better to have the versions at the same time for fairness, because otherwise, if we adopt it, the Lusophone and the French-speaking countries, they adopted what they did not understand. That's the problem. So it's always good to have all the versions at the same time. Usually that's better practice, just for this thing. But probably we'll come back to this topic. But one piece of suggestion that some of us have, which we think could be potentially a winning formula for our region. Let's have a database of all these things we want to do. The technical team can help us. For example, if you ask any of us, most of us ministers here, what is manufactured in West Africa when it comes to drugs and medical consumables? I don't know. Who knows here? So how can we leverage from what we don't know? So probably you have a database, Nigeria manufacturing, Togo, Ivory Coast, Cote d'Ivoire, Ghana, Gambia, and so on. So those databases are going to be very helpful. Database of experts, epidemiologists, physicians. How many does Nigeria have? How many does Gambia have? So we can now look, that will help you very much in the implementation of the agenda of the region. Thank you.
Thank you so much, Honorable Ministers. This is very well noted. Before we come back from lunch, we will have the 3 version. The team is working on this. This is very helpful, your intervention. So for workforce, we are also working on this. We already have agenda for this. We went for a need assessment, and we realized that actually the need is not what we have in terms of epidemiologists, in terms of physicians, nurses, and others. And we are trying to project this in the 5 years. How do we organize ourselves? So we already harmonized the curriculum training in terms of advanced FLTP and others. We did the validation last year in Nairobi. So we have agenda for this, but this is for all the Africa. We need to come back as West Africa to take this as West Africa. So with the chair that will come soon, I will work with him to see how we address this in West Africa to address the needs. Yeah, thank you so much.
Thank you so much, RD, and thank you, Honorable Minister, for the contribution. Do we have any other additional comment? Silence means that we are okay. I would like to call upon our brother from the legal division to guide us through. Brave, to guide us through the next session, which is election of the Resco chairperson and vice chair. This is an agenda that we as the secretariat, we want to wash our hands so that then the ministers can sit on their own and decide, us will be spectators, but he'll guide us whether we stay in the room or whether we have to get out of the room. Call upon Brave, come and share your guidance on this particular session. Brave, please.
Thank you very much, Dr. Elfas, honorable ministers, distinguished ladies and gentlemen. So I did introduce myself earlier, so I'll skip that part. So we've come to the most interesting part of the meeting. And for us from the legal office, we provide guidance based on the statute, based on the available frameworks in Africa CDC. And also, like I mentioned earlier, some of the issues around rules of procedure, we will also seek guidance from RITAC and Resco, especially once the Resco is inaugurated and fully functional. So let me go back to my colleague Chioma did a very good job trying to take us through the draft terms of reference and framework. And I think she also discussed aspects like the draft aspects around elections, selection of, so we need a chair for the Resco and we need a vice chairperson. And then of course the RCC plays the secretariat role led by our able director. And so from the Resco, inaugural Rescos that we've done, we usually have embedded two procedures. One is, of course, by way of elections. And as alluded to by my colleague, a simple majority then would take it. That would really be by secret balloting. But also, we've realized that because we're coming together, consensus building becomes also a very important part of selecting our leaders, especially when we are in West Africa. Now, my country is Zambia myself, so it's such an honor to find myself in West Africa. And in West Africa, we have Francophone, I have to read it, by the way, Francophone, Anglophone, and Lusophone. Now, I always forget Lusophone, I don't know why. But I remember Francophone and Anglophone. And so because of that, we feel it's always important that we also allow, because the Secretariat does not dictate. The Secretariat will guide, will do the as instructed by the Resco to make sure that governance, we run prudently and we're able to achieve our results. So as a result, we encourage consensus building from our honorable ministers, and of course also from their duly appointed representatives. So we realize that in the room today, we also have the duly appointed representatives from the member states that are present with us. And of course, when I did my maths, I could tell that we have a quorum. I'm not sure at this time if we have any honorable minister or any of their duly appointed representatives online. Do we have any? Benin. Is that the honorable minister? Okay. Okay, thank you very much. So I think what we'll do here is we will pause at this time and request your guidance. Like I said earlier, one option is to go by way of elections. The other option is to go by way of consensus. And also just to guide, if we go by way of consensus, we also encourage balance. We already have, for example, a chair for RITAC who's from, what country is that? Modu, from Gambia. Yes, the chair is from, okay, yeah. I just wanted Modu to be awake, yes. So the chair is from Gambia, the vice for the RITAC is from Cape Verde, and so Capo Verde. And so then for RITAC again, we allow that the honorable ministers can deliberate and see how the balance would be done in terms of Francophone, Anglophone, Lusophone, and also in terms of coverage around ensuring that there's a balance and we don't have, for example, one member state that is vice or chair on both, but we leave that to the honorable ministers. So maybe at this point, I could pause and request for guidance on the way forward. What would be the favorable way forward? And then we could agree. Maybe we can have anybody guide us from your experience and your, yeah, thank you. We can be guided.
Very much. Thank you. And thank you also for already excluding me. Because the retail chair is from Gambia. So you already prepared your mind to exclude me. But anyway, that's that, but that's just by the way, that's a joke. But I think yes, you are right. It's a consensus, it's a family. So, and in any case, I was also not interested to be the chair. but that's just by the way. And I think the method we use, probably sometimes these are better done in closed door. This kind of high-level selection processes. Usually, there is a preliminary discussion amongst the people involved themselves. When ministers select from amongst themselves, usually they just want to be alone. That's the standard, right? That's I've witnessed over the past few years that I've been in this position. So that is that. Now, sometimes it's difficult how you say we go by consensus. Who kickstarts that process to say let's go by consensus? Who kickstarts the process to say let's go by election? Well, the inaugural process is sometimes this how difficult they were. If they were a chairman from amongst us, he could say, ask. But since you want to be careful, you are not a potential member, then. But I think probably we could have just a little tete-a-tete from amongst ourselves. That's usually how it goes. Then we decide what method do we use, and then how do we come up. Maybe there's already a consensus candidate. We don't even know. Maybe there are people who want to vie. How do they vie for the position also? Then maybe we could have that and then come back, whether it's here or whether it's a side room. So we come back and decide on how to go about it. I don't know what the take of my other colleagues is on that, right? Thank you.
Thank you, Honorable Minister. I think we can get other views, if there are any other views. Yes, please go ahead.
Okay, as we are at a critical point of decision making, one thing I want to bring to our attention is the issue of gender sensitivity in our leadership structure. So may we also consider gender. Thank you.
Thank you very much. Okay, any other? Okay, please go ahead, sir.
Yes, just as a rider to what my colleague just said, it's not individual, it's countries.
Yeah.
So whatever it is the country that is being represented. So it does not really apply. Thank you.
All right, thank you. Any other remarks?
Not the president.
Okay. So also just recognize the director of a cabinet from Benin, who's representing the honorable minister. They've joined us virtually. They're online. Thank you very much. So maybe at this time, as guided by the honorable minister and the other ministers as well, we could probably leave the ministers as well as the duly appointed representatives of the ministers present, and of course those that are online. We could leave you in the room. I'm not sure if there's another room prepared, or we leave the honorable ministers here. I can be guided. Oh, we will leave? Okay. Okay. So we will, in short, get out. Please, you can start making your way to the exits. Then the ministers will remain here. The honorable ministers remain here. If you are not a minister or duly, you can, but we're not asking you to go home, please. We're not asking you to take leave. We're just asking that you stay outside, take some coffee, and then you'll be called back in the room when the honorable ministers are done. Sir, thank you. Yes. So, yeah. So, okay. So the representatives will stay. On, so the representatives of the ministers should also remain. Yeah, because you are representing your country, so please, you can remain in the room. Mhm. The representatives of the ministers can remain. And also, if you are online and you are not representing the minister, you can exit the platform. You can exit Zoom at this time. I think, yeah, I think we can allow the director to remain, and then I can step up. Okay, and then I can stay to take notes. Thank you. So we have the director of cabinet from Benin online. I'm not sure if they're still online, but they're online. Yeah. Okay. I've actually been informed that those stepping outside can proceed to lunch. Yes. About for 45 minutes. Yeah. Those going outside can proceed. Please do not go home. We still need you after the 45 minutes. Yeah. So I think the honorable ministers can, and the duly appointed representatives can maybe choose an interim chair who will assist with deliberations. And then as a secretariat will sit in and write the notes and outcome of the meeting. Yes, Honorable.
Okay, sir.
Sorry. No, typically what I've also
Honorable
observed.
Minister, sir, I think at this point we may not use the mic.
Muito obrigada. Fica a palavra em relação ao posto do vice-presidente.
We together? Are we together? Okay. So, but we still have a member state. Yeah. Chair, should we go ahead or we give 2 minutes to people? We go ahead. Yeah, because the vice chair is also not, yeah. Let me look at him, just 2 minutes. Yeah, welcome back again. So while we are waiting for the Vice President to join us, I just want to give you a quick update about what happened. So we have a very great time, election times, as usual in Africa. So at the end, we came up with our chair and vice chair. So we are going to invite our chair, and the vice chair will join us now. So the chair will officially launch this inaugural Resco meeting. So the launch is, the chair will give us a quick speech, and then we take a group photo with ministers, is the launch. And then we have the panel discussion. We will make it very short. We really want to take advantage of the presence of our ministers to hear about them in terms of health security and also health financing. So with your permission, allow me to invite our chair, Ghana, and vice chair, Guinea-Bissau, to join us.
Thank you very much. My vice, the Minister responsible for health in Guinea-Bissau, the Director General for Africa CDC, His Excellency Dr. Jane Kaseya, the Regional Director for Western Regional Coordinating Council Center, Dr. Alinon Koku, my colleague ministers from the various countries, the Chairman of RICTAC, Dr. Yusafa Toure, partners and esteemed guests. Permit me to express my deep sense of gratitude to Africa CDC for putting such a historic inaugural meeting to establish a steering for the Western RCC of Africa CDC. To my colleague ministers, I'm grateful for reposing such enormous confidence in Ghana and in my good self to serve as chairman for the Regional Steering Coordinating Center for Africa CDC. Please be assured of Ghana's genuine commitment and solidarity to this regional effort. My colleague ministers, I'm well aware of your busy schedules in your respective countries, but I will encourage you to prioritize the activities of this establishment to give it the needed significance. Ghana's health policies are deeply aligned with Africa CDC's mission to strengthen Africa's public health institutions to better prevent, detect, and respond to disease threats and outbreaks. Our policy framework focuses on building resilient health systems, preventing and controlling the double burden of infectious and non-communicable diseases anchored towards achieving universal health coverage whilst promoting digital health innovation, all of which are core pillars of Africa CDC strategy. As chair of this steering committee, I am committed to steering the affairs of this committee to provide the needed oversight for the Regional Coordinating Center and Advisory Committee. I will work collaboratively, and the emphasis is mine, collaboratively, and tirelessly to provide needed strategic direction for addressing the health challenges of the West Africa sub-region, including outbreaks of Ebola, Lassa fever, and yellow fever, among others. I recognize that our success depends on strong partnerships and collaborations with our partners and communities. This steering committee will further strengthen our collaboration with WAHU, WHO, and other regional and global partners to share knowledge, expertise, and resources. We will also engage with regional economic communities such as ECOWAS to leverage experiences and resources in responding to health emergencies. Let us work together to strengthen our health systems, prevent and control infectious diseases, and promote digital health innovation. Let us demonstrate our commitment to the health and well-being of our citizens and to the vision of a healthier, more prosperous West Africa and Africa as a whole. I thank you for the opportunity. So at this moment, the Resco is duly launched. Thank you.
So we will have the panel discussion. Will be moderated by the chair of the RITAC, Dr. Toure, Dr. Yusufa Toure. And then we will have Okay. We have 3 ministers, the Honorable Minister of Health of the Gambia, and Togo, Ghana, and Guinea-Bissau 4. We need 4 chairs. 4. So I now call on the Madam Ministers to take their seats. Honorable Minister of Health of the Gambia, you can sit here, and then the rest can sit, and the moderator will sit here. Okay. Let's give them a round of applause, and then also here to hear. So now, Chair, you can now take up the floor and then moderate the session.
Okay. We are ready to go. Let me first of all welcome the honorable ministers, of health, to these very important, panel discussions. It is important in the sense that, without money, nothing works. In the case of health, we don't have a choice. Something must work, and you could see in the absence of what is required to make those things work, we are doomed. But we all believe these are experts in diverse fields, especially in health. And with their experience and their expertise, we would seize this opportunity to listen closely or keenly, to them and share their thoughts on how health should be financed. Given the limited time we have, we would ask only one question from each of them. But I want to see if we can allow them to each introduce themselves, to the audience, before we get into that. But even that, I want to believe would take our valuable time. So before they respond to the question, probably they can take the opportunity to tell us something about what they are doing. I would want to start with Honorable Dr. Chin Dari, the Honorable Minister of Health, from Togo. What role do public-private partnerships, that is PPPs, play in ensuring innovative health financing? And how can they be optimized within regional frameworks? Honorable Dari, would take that question.
D'accord, merci beaucoup. Je me présente, je suis le professeur Tiendare, je suis le ministre de la Santé et de l'Hygiène publique du Togo. Je viens d'être informé de la thématique, donc je n'avais pas l'information à temps pour assez bien me documenter sur la problématique, mais néanmoins, puisque cela rentre dans notre gestion quotidienne, je partagerai avec vous quelques éléments sur la mobilisation, bien sûr, des ressources financières et surtout en matière de partenariat public-privé. Je vais commencer d'abord par présenter la situation. La situation aujourd'hui, nous la connaissons en matière de santé, c'est une situation de raréfaction des ressources financières. Et cela s'est aggravé avec la suspension de la coopération, pour ne pas dire de la subvention du gouvernement américain. Nous savons tous l'apport de ce financement sur l'impact, bien sûr, de nos différents programmes et projets en matière de santé dans nos pays respectifs. Nous savons tous l'apport significatif de ce soutien financier de l'État américain. Donc, en plus, bien sûr, de cette suspension dont je viens de dire, cela impacte également sur beaucoup d'associations et beaucoup d'autres possibilités de mobilisation de ressources. Et tout cela ne peut qu'impacter ou avoir d'impact sur nos systèmes sanitaires de façon générale dans la sous-région et beaucoup plus également dans nos pays, dans nos différents pays respectifs. Je voudrais partager un peu l'expérience du Togo avec vous face à cette situation et puis ressortir un peu certaines pistes d'orientation ou certaines suggestions, voire plutôt certaines voies d'approche que nous sommes en train d'implémenter ou de vouloir mettre en place. Nous avions essayé dans un premier temps de faire pour ne pas dire chercher à avoir un impact de façon exhaustive de la suspension de cette coopération sur les activités au niveau du secteur de la santé. Nous avons évalué l'impact et l'évaluation de cet impact est bien sûr fait également par nos partenaires, puisque nous avons eu des séances de travail et l'approche que nous avions mis en place, c'est qu'il y ait une évaluation au niveau du département de la santé de façon indépendante et que la même chose, le même exercice soit fait aussi par nos partenaires. Et après, on fera des croisements, des analyses et avec des pistes, bien sûr, d'approche, de solutions pour voir comment essayer de réajuster ou de réorienter les ressources vers des activités qui sont impactantes et qui sont beaucoup plus inclusives. Donc, ce travail est fait aujourd'hui. Nous avons les résultats de cette évaluation au niveau de notre département. Nos partenaires qui sont dans le chef de file, bien sûr, est l'OMS, est également en train de faire cet exercice. Ils sont presque aussi à la fin de cet exercice. Et nous nous sommes dit qu'on allait avoir, puisque nous avons mis en place un comité sectoriel d'échange qui réunit le ministère de la Santé et tous les partenaires qui interviennent et qui financent dans le secteur de la santé. Nous nous rencontrons une fois par trimestre, mais avec cette situation particulière de la suspension, nous nous sommes déjà rencontrés 2 fois pour ce premier trimestre, où la première rencontre, c'était de pouvoir discuter, voir quels mécanismes, quelles sont les approches. Et le deuxième, bien sûr, la deuxième rencontre qui se situe dans les rencontres habituelles trimestrielles que nos partenaires et le ministère, bien sûr, ont l'habitude de faire. Donc, il ressort, si je peux m'exprimer ainsi, surtout nous, à notre analyse personnelle de la situation, que nous avons ce devoir aujourd'hui de trouver des mécanismes qui puissent nous permettre de maintenir nos activités et toujours en visant les résultats et les objectifs que nous nous sommes assignés. Cela nous oblige à réajuster les mécanismes. Le premier réajustement, c'est de faire de telle sorte que nous puissions avoir des activités qui sont intégrées. Donc, une activité, les activités qui se faisaient de façon isolée, nous sommes en train de travailler pour faire de telle sorte qu'au cours, par exemple, d'une seule séance d'atelier, que nous puissions regrouper 2 ou 3 activités. Cela permet bien sûr de capitaliser et de mieux orienter nos ressources en visant les résultats. La deuxième, donc, nous pensons que cette approche également au niveau sous-régional pourrait également être, disons, implémentée. Le deuxième réajustement, bien sûr, que nous sommes en train de faire, c'est la priorisation de nos activités de toute façon. Nous avons ce devoir de prioriser les activités. Donc, il y a certaines activités qui sont beaucoup plus inclusives et qui sont beaucoup plus impactantes. Donc, nous avons le devoir aujourd'hui d'orienter les ressources vers ces activités beaucoup plus prioritaires et qui permettent au système d'être debout, le système sanitaire d'être debout et de ne pas perdre, bien sûr, de son efficacité. Et donc, les ressources sont plus ou moins orientées vers ces activités prioritaires. Nous pensons également qu'au niveau régional, cet essai ou cet exercice également pourrait se faire au niveau régional. Le troisième réajustement que nous sommes en train de faire, c'est d'ouvrir, vous savez, en situation de crise, des fois on trouve d'autres opportunités. C'est de voir un peu quelles sont les d'autres portes qui pourraient s'ouvrir face à cette situation actuelle. Donc, avec les partenaires également, nous nous sommes dit que nous pouvons explorer d'autres pistes parce que on s'est retrouvé dans un certain confort de par le passé, on s'est habitué à ce confort, mais face à ces situations, nous sommes aujourd'hui obligés de sortir de ce confort et d'aller faire de la prospection et de chercher à voir si nous pouvons ratisser ou aller vers d'autres partenaires peut-être que nous ignorons entre-temps ou renforcer la mobilisation de toute façon à travers d'autres sources et à travers d'autres partenaires. Nous pensons également qu'au niveau régional, cet exercice également pourrait se faire pour aller vers d'autres partenaires, explorer, faire de la prospection d'autres partenaires en sortant de notre confort habituel, des partenaires traditionnels qui nous accompagnent habituellement dans le système sanitaire. Donc, voilà un peu les quelques exercices qui sont en train d'être faits au niveau de notre département pays et nous partageons un peu les quelques pistes. Telles que je l'ai dit, l'exercice est en cours. Nous n'avons pas totalement abouti et je vais dire, nous n'avons pas totalement finalisé les résultats, mais déjà, les premiers que nous avons, les premiers mécanismes ou décisions qui sont en train d'être prises, c'est celles que nous sommes en train, bien sûr, de partager avec vous, prioriser aujourd'hui nos activités au sein de nos départements, avoir aujourd'hui cette approche d'activité intégrée, que plusieurs activités qui se faisaient de façon isolée, que nous fassions de telle sorte qu'au cours d'une seule séance ou atelier, que plusieurs activités puissent être menées et bien sûr aller aujourd'hui vers la prospection en cherchant d'autres portes, d'autres sources pour maintenir toujours nos systèmes assez robustes. Donc voilà, chers modérateurs, les quelques éléments qui me viennent, je l'ai dit, ce n'était pas une thématique que j'ai eue préalablement pour mieux meubler, mais les quelques éléments que j'avais les voici. Je reste toujours disponible. Merci.
Thank you very much, Professor. That has been very clearly dealt with. You talked about assessing the situation and knowing which areas will be impactful and getting out of the comfort zone to look for new partners, get new partners, because the conditions are that we have to try new ways. Now I would move to Honorable Dr. Kwabena Minta Akando, our new chairperson. Congratulations. But let me take this opportunity to see how we can get you to tell us how regional organizations like ECOWAS African Union, can help coordinate cross-border financing strategies that will benefit multiple countries, especially in tackling, health crises like pandemics.
Thank you very much for the opportunity. And let me start with what we do in Ghana, how we finance health in Ghana. The major financing policy in Ghana is called the National Health Insurance Scheme. And so in Ghana, the National Health Insurance Scheme seeks to draw money into the National Health Insurance Fund by levying, the citizenry. Whatever you buy in Ghana, you pay what we call National Health Insurance Levy. And so everybody in Ghana contributes to what we call the National Health Insurance Levy. Unfortunately, the previous government capped it. When I say it capped it, it means that it gave it a ceiling where beyond that ceiling, the rest of the money will go to the presidency. But the present government, or His Excellency John Dramani Mahama, the current president, has decapped that national health insurance. So now everything that is paid in the name of national health insurance levy comes into the fund directly. So that is a major financing scheme that we have in Ghana. And there are a number of diseases on the list of the national health insurance, scheme. Quite apart from that, what we have realized is that in order to facilitate the universal health coverage, we need to, erase or eliminate the financial barrier. And so what we are heading towards at the moment is what we call free primary healthcare. So in Ghana at the moment, if you are accessing healthcare from the CHIPS, that's the basic level, or the health center, we are saying that you shouldn't pay anything, so that it will eliminate the financial barrier, especially for those in the rural areas that cannot afford healthcare. So these are some of the strategies we are putting in place. Another one that we have also noticed is that the rate at which the NCDs, the non-communicable diseases, are killing the people in Ghana is an alarming rate. At the moment, mortality rate for NCDs is between 42 to 45%. And therefore, there was the need for us to do something about it. What the current government is doing is to establish another fund, basically to tackle the NCDs. So we call it Ghana Medical Trust Fund. Ghana Medical Trust Fund. So we are looking at diseases like the cancer, the cardiovascular diseases, the kidney-related diseases. That's what we are concentrating on at the moment. Then we also, at the point in time, bring in the public partnership, private-public partnership, where we allow individuals to liaise with government to establish some facilities at the government hospitals so that they can give quality services to the people. Because what is important is that if the citizens go to the health facility and it gets quality healthcare, the person would not care about whether or not the facility is for government. What is important is quality health care. And so that's what we are looking at. At the moment, we inherited some health facilities we call Agenda 111. So the president has directed that we audit all these ongoing projects, and then we bring the private sector in to be able to complete all this so that it will be beneficial to the citizens. Now, if you ask me how, ECOWAS and those entities will be able to be coordinated well in order to maximize our health financing in the sub-region. What I want to say about that first and foremost is that when I became the minister responsible for health, what I realized is that the various partners do not reconcile their activities with government priorities. And so you realize that the partners will then be doing their own things and government focuses will also be on another thing. So what I think we should all be doing as a country, in our respective country, is to be able to reconcile all these partners' activities with the priority areas of the government in power. In that way, we'll be able to maximize whatever resources we have in the country. In that way, we'll be able to maximize whatever resources. So we realize that there are things partners are doing and you do not necessarily need to waste money on, and government will focus on something else that the partners are not doing. And for example, at the moment, USAID they have withdrawn their grants, or they've done cuts down. And so before then, they were assisting us to distribute our medications to the last point. We'll call it last mile distribution. And so they were renting vehicles for the distributions and paying for us. But we cannot continue on those paths because we don't have that much money. And so there should be that innovation. What is that innovation? The innovation is that let's go in, we have what we call central medical stores and regional medical stores in our various regions. So we can go in each region, we will have some kind of establishment where we have vehicles for the various regional medical stores to be doing the distribution. When it comes to fueling the vehicles, no matter what, government will be able to mobilize resources to finance or to fuel those cars to be able to distribute the medications or the logistics we need to distribute to every corner of the country. Resources in the sub-region, and then be leveraging on each other's strength. I think that we'll be able to go a long way to finance our health deliverables in our respective countries and the sub-region. Thank you for the opportunity.
Thank you very much, Honorable. I think we have a lot to take from that, the National Health Insurance Scheme, and cascading that to another level where non-communicable mortality is being handled. But you said one thing, I think that is a take-home, reconciling partner priorities with the priorities of, government, is key. And we agree that if we can do that at the level of, ECOWAS and AU, with all the countries, then we would go a long way. Thank you very much, for that insight. I would now move on to Honorable Dr. Pedro Tipoti. How can innovative financing help build resilience in health systems, particularly in the face of future global health threats or economic downturns? Honorable Minister from Guinea, who want to take that.
Obrigado por me ter passado a palavra para exprimir sobre o financiamento e estratégias a adotar para que a África definitivamente possa assegurar o sistema de saúde em cada país concernente. É verdade que ao longo desses tempos, desde talvez a criação da OMS, nós, os países africanos, entregamos a saúde a estrangeiros. Não quero ser crítico aqui, mas a verdade é que dependemos muito do financiamento estrangeiro, através das diferentes parcerias que possam ser anotados aqui. No caso da Guiné-Bissau, e isto é importante salientar, que as capacidades financeiras variam de país para país e as possibilidades, mesmo as competências também. Já que estamos enfrentando a ameaça de não podermos assegurar o nosso sistema de saúde, faço um apelo mais do que dar algumas intervenções no sentido de dar sugestões, no sentido dos países africanos repensarem como financiar o sistema de saúde. Nós, por exemplo, na Guiné-Bissau, já estamos a pensar que, apesar de dificuldade financeira, mas é preciso pensar num sistema de, por exemplo, nas exportações que se possam realizar no país em função dos recursos que tem, aplicar uma taxa destinada a assegurar a saúde. É verdade que, aplicando qualquer taxa na exportação ou importação de um minério, de um recurso natural, isso implicará realmente na vida das populações. Mas é preciso também reconhecer que a saúde não é barata. É preciso que todos nós consintamos o esforço e o sacrifício para o melhor de todos nós. Não é desejável que alguém esteja doente, mas é preciso sempre atender os doentes. Portanto, eu penso, senhor moderador, que se os países africanos, independentemente do orçamento que se aplica a cada país no seu para o setor da saúde, é preciso que os países pensem nisso. A aplicação das taxas, quer da forma direta ou indireta. Como disse, no caso da Guiné-Bissau, estamos a pensar na exportação de castanha de caju, aplicar uma taxa, mesmo que seja uma taxa ínfima, mas que tenha um reflexo para podermos acudir e atender alguns problemas. A estratégia de que se falou, eu penso que é preciso ter a coragem de enfrentar os parceiros. Porque o que acontece às vezes, não sei se é o exemplo de outros países, é que os parceiros, quando vêm com algum recurso para ajudar o país a enfrentar com as dificuldades, eles tentam impor as regras. Impor as regras em função daquilo que é o objeto e o objetivo da sua participação no sistema de saúde. Dou um exemplo. Quando se fala da mortalidade materna infantil, quase que todos os parceiros se engajam. É a situação da atualidade, é fácil encontrar os financiamentos para esse tipo de ações, mas esqueçamos que podemos tratar as mulheres, as nossas mães, sim, devemos, porque elas que nos dão a vida, mas é preciso também pensar depois da mãe dar à luz. Se não tratarmos de outras doenças, o que será daquele bebê de que pretendemos que tenha saúde? Por isso, devemos ter a coordenação entre os parceiros e que cada país defina as prioridades, que sejam os países a definirem o objeto da intervenção para que não sejamos estejamos fora daquele princípio real de tratar da saúde pública e, sobretudo, porque o nosso povo-alvo é aqueles que vivem nas extremidades, nas aldeias, que não têm como, talvez, suportar as despesas. O meu colega que antecedeu falou de a gratuidade de financiamento nos nossos hospitais, que devem ser cobertos de alguma forma. E esses países, aliás, esses parceiros, quando intervêm, ajudam o governo. Mas é verdade também que nós não podemos estar dependentes eternamente dessas ajudas. Por isso, estrategicamente, é preciso coordenar as ações de cada parceiro em termos estratégicos para o financiamento da saúde pública de cada um dos nossos países. As sensibilidades são diferentes. Eu penso que, se nós adotarmos essas reuniões concertadas com os parceiros, podemos alinhar, porque eu digo aqui com toda a responsabilidade que, se formos ver o orçamento do Estado de Guiné-Bissau, podemos encontrar não mais de 6% que o Estado adota como financiamento do setor da saúde, o seu PIB. Mas se formos ver o montante, o dinheiro que circula no sistema de saúde vindo dos parceiros, talvez eu estaria aqui em condições de dizer o Ministério da Saúde de Guiné-Bissau é o ministério que mais tem fundos. Mas esses fundos não são coordenados. Cada parceiro impõe, e o pior de tudo, por que eu insisto nessa questão de coordenação? É que há programas financiados pelos parceiros. Chega ao fim de algum programa, dizem que o país não tem capacidade de observação. Mas porque mesmo esses parceiros não têm capacidade de exercer todas as atividades que planearam para um determinado ano. Portanto, é preciso ser claro, se querem ajudar, se querem promover a melhoria no sistema de saúde, devem também saber compreender os nossos países em função da realidade que cada país enfrenta. Portanto, meu caro amigo, essa é a minha contribuição nessa primeira parte. Obrigado.
Thank you very much, Honorable Minister. The issue of dependence on external partners and the need for taxes dedicated to healthcare and partner coordination and positive negotiation with these partners to ensure that everything is in the best interest of the state. Thank you very much for those. But with that, we would now move on to the last speaker, not the least, Honorable Minister for Health in the Gambia, Dr. Amadou Lamin Samate. How can innovative health financing models be designed to ensure that vulnerable populations, such as low-income groups or rural communities, benefit equally from improved healthcare funding? Honorable.
Yeah, thank you very much, Mr. Chair. And thank you, all the panelists who spoke before me. Health financing, by virtue of the fact that you decided to bring it up for us to discuss, shows the importance of the topic. Now, why do we have so many problems in the health sectors across the region? Most of it is because we do not have the financial muscle to deal with many of those problems. Of course, it's not all based on financial inadequacies. Complexities of factors contribute, but most of the time we don't have the resources. Why don't we have the resources? Most of our countries are poor. Even if our potentials are there, so most of our countries have high potentials, but they are not tapped to the extent that we consider ourselves rich. I was opportune to visit one Western country. Their population close to that of our country. Now, their health budget, health alone, was about 4 times more than our national budget, our whole country. That's their health budget. Now, can we have the same level of services as they do? Sometimes when our Gambian compatriots in the diaspora, they criticize me and my ministry. You are not doing this, you are not doing that. I say to them, come back. Why are you there? Why are you where you are? Because you went there because the resources are there. We are doing what we are doing because we don't have the resources. So we should rather be commended. Now, and the sad reality is, in our region, the human body is the same, whether it's Japan, Tokyo, Gambia, Liberia, Nigeria, Cote d'Ivoire, Japan, or US. If a patient has acute appendicitis, the treatment is exactly the same. The operation is the same. The equipment we use are the same. We cannot say we'll give water instead of antibiotics because we are in Gambia. The antibiotics are the same. And we do not manufacture any of these. They come from those areas. So look at it. They have more money. We have little money. We buy from them, pay transportation, shipping. The suppliers put on profit. And with our poverty, we buy these things at a much higher cost. These are the challenges we face. These are the daily realities. That is why occasionally, frequently, we have challenges in supply chain, yet management. We have shortage in drugs, in equipment. But yet still, we have to provide the life-saving services for our people. And now, most of, or quite a big chunk of what we also get, we have to service the debts, debt servicing. Some countries, what we spend on debt servicing is more than our health budget. And most of those debts, we inherited them. And now, but we have to pay them because if we don't pay them, there are consequences. So we have big dilemmas. So that means what can we do? We have to be innovative. We have to be innovative. We have to look inwards. Now, innovative financing is good to look for other sources of funding. As we are being innovative, we are told recently that some sources of funding will stop. So you see our dilemma in our region, in Africa. But I think it's important to look inwards. Before we go to revenue coming in, the revenue that's already there, how do we manage it? I think sometimes we have inherent challenges in managing revenue. Included in that, sometimes corruption. We have to deal with that squarely. We have to abolish corruption in all the sectors, especially the health sector, because corruption in the health sector has a direct impact on the lives of the patients. It's as simple as that. So that one, in Gambia, when I became minister 6 years ago, now, that's one of the things I had to deal with. I say, cannot be business as usual. We have to close the loopholes. And believe me, it was a lot of fight. It's still a fight, but it is yielding results because we are able to use what the little we get for patient care. But it did not just stop at that. It also boosted the confidence of the partners in us. And then we started getting more and more support from virtually all the partners. They are helping us in health infrastructure, which is very good. But apart from that, it also helped even get confidence locally. The finance minister is more confident now to give the Ministry of Health funds because they know, they see the structures. In fact, I beg him, I say, finance minister, we are doing A, B, and C. Let's go and you see it yourself. So he knows we are confident in the work we are doing for us to invite him to go and look at the impact. So I think we have to look inwards and close those loopholes. When there are austerity measures, austerity situations, we have to ensure that we maximize capacity. And also prioritization of expenditure is very important. Too often than not, when we get little projects here and there, the first things we think of is buying a new Prado, new 4x4, everybody, every health worker, every director, every program manager. Quite a lot of the money goes to that. And because they are government properties, most of us in our regions, we don't take good care of them. If a vehicle, our own vehicle, is to last 10 years, government vehicle, it lasts for 3 years. Another 3 years, another vehicle, another 3 years, another vehicle. Maybe those vehicles, the cost should go to new health posts, new health facilities. So we have to look at that. In Gambia, we are trying to do that, but it's a lot of fight. Even with sometimes the people who are supposed to support me, they fight because they also don't get the benefit. But another thing is the syndrome of workshop, seminar, workshop, seminar, workshop. It is a big problem. So, and then it gets so bad sometimes that even the things we are supposed to be doing ordinarily as part of our work, they say, Honorable Minister, there's no funding for this. I say, organize people to teach them A, B, and C. Honorable Minister, we couldn't do it because there's no funding. Develop policy guidelines for A, B, and C. There's no funding. But we are paid salaries. So that culture has to change so that we are able to deal with a lot of things that our little resources can get us. Then the resources, if we are unable, even if we get billions and billions, they will go down the drain. So we have to strategize, make good use of our resources, so that when we have innovative financial modalities, it will not be -1 + 1 -1 + 1, then we stay at 0. We have to keep on adding additional financing, additional output, additional financing, additional output. So with all these measures, Gambia is able to implement things like tobacco tax, which is a very good innovation because quite a lot of millions are generated from taxing tobacco, and then now we are thinking of the tobacco levy. Now, the challenge certainly is when the tax comes, it goes into the national basket. So getting it from the Minister of Finance becomes a problem. And the argument is sometimes the quarrels. We say, well, this is tax from tobacco. It's supposed to come to the health sector. He said, but the other money the health sector gets come from other sectors. So you see the argument. But nonetheless, we are pushing so that tobacco-related tax and other sin tax, alcohol tax, and so on are able to go directly to deal with non-communicable diseases. Another aspect we've also introduced, just like our colleagues have said, is the National Health Insurance Scheme, which we believe is going to be an additional source of funding for the health sector. Yes, the people are going to contribute. There are going to be contributions from the citizenry, but those contributions alone cannot run an effective National Health Insurance Scheme. So government is now looking for other avenues from telecommunication tax, tax percentages from telecommunication, from other levies to additionally fund the National Health Insurance Scheme. So which is an additional thing, indirectly funding the health sector. The PPP regimes in many of our countries, especially in Gambia, are not well developed when it comes to the health sector. Now, we've asked the World Bank. World Bank is supporting us develop a PPP strategy because we've also realized that government buys a lot of equipment, put up a lot of good infrastructure, but a few years down the line, they go down the drain. The reason is, in some cases, government is not so good at managing some of these things because governments have a lot of considerations, especially in small countries like ours. So we believe the private sector will bring in more investment, and then equally speaking, it will bring in efficiency and more accountability because the private sector people don't want to lose money. When they invest, they have to make sure that people come to work on time and people deliver. And they'll take the records, they'll keep the records, and we believe that partnership will help us. One very interesting innovation we have in Gambia with the support of the World Bank and the government of the Gambia is what we call the results-based financing. Rather than looking just at the input, we look at the output, and it has been yielding tremendous dividend in the sense that health facilities are recruited and they are paid bonuses based on their performance. The number, if they deliver this number of patients, this number of women, they get an allowance. They immunize this number of children, they get an allowance. Their facility is clean, they get an allowance. The data, the record system is good and neat, they get a little allowance. So this has proved to be very, very efficient. So in fact, they decide to compete actually on getting more deliveries in the health sector. They will even canvass in the communities for women to come to deliver in the health sector. Because when women come to deliver in their facility, they get a little bonus. So this results-based financing has been a very, very good model, and it has improved on the hospital-based delivery. It has improved on our immunization rate, and so on and so forth. So we believe together, when we come together, we can leverage also the actual indigenous private sector. Indigenous business people, in many of our cases, do not contribute a lot to the health sector. And I think we are trying to see how we engage them to let them understand that health is everyone's business. Investing in health is everyone's business. Just a few days ago, we had a business group that came and renovated children's surgical ward in the Gambia, gratis, because that was part of their corporate social responsibility. And we believe if other business people are also brought on board, these kinds of trends will continue. Thank you very much, Mr. Chair, for giving us the opportunity to share a little bit of our experience with the team. Thank you.
Thank you very much, Honorable Minister of Health for Gambia. The key issue at the earliest part of the deliberation is attitudinal change. You know, how do we, close the leakages? And if we are able to do that, we would be able to, put a lot of resources for ourselves within the country. And I think this is also something we need to all take home. There are supply chain challenges and, taxation, has come up, privatization, and, the need for private sector coming in because they have a social responsibility to the people. So that's good. And you can imagine if we had enough time with this, caliber of people, these are not just permanent secretaries. They are not directors. They are ministers. That means they are responsible for policy, so they can move things around within their respective countries. So when they speak, we know very well that they talk about things that they have all the opportunities to do at their own level. So this type of opportunities we will continue to harness, to leverage on, to see how we can get them on board, to talk to us, on how health, can be managed, within the region. So I would thank all of them very much. I want to see if we have time for, questions, which we don't. So I would crave your indulgence. My apologies, to all of you. I know you would have loved to, ask a lot of questions from them, but another time, will come our way when we would be able to interact with these, very important people on. Yes, it is. So let's take two questions, please. Two comments from a lady, preferably. Yes.
Thank you so much. Honorable ministers, this is a real classroom learning for me. I mean, I was just putting down so many things. But something come across my mind, and I was thinking that health financing, healthcare system, without the effective and efficient healthcare workers, I don't know how sustainable that will be. No matter how much you invest into the healthcare workers are the major people that make this to work. How about looking at area of retention? Because you keep financing, you put in all those things, and then you go back to the healthcare system, the hospitals. They look like graveyards sometimes, and very confusing system because they are not well paid. So I don't know how we can actually, because I know the new public health order for Africa under the African CDC also has the workforce initiatives, strengthening the workforce. And that's the key for public health system. So how do we marry this together to make sure that we're not just throwing the money into the ocean and then the workforce itself are not happy? They've seen a lot. I can see the description from all the countries, and then we want to eliminate corruption. How do you want the workforce itself to be happy to do the job when they are not happy with what they are earning? And that's why you see a lot of issues around retention. And then we can't even talk about sustainability. I think these are all my concerns around this health financing. Yes, it's good to finance, it's good to bring in all those equipment, but who is going to manage them? Where are the workforce? So these are my concerns. Thank you, sir. Over.
All right, let's have the last one from the back. Okay.
Thank you, Chair. Bon, parce que je voudrais dire quelque chose de très sévère, je vais dire ça en français. Je vous remercie très sincèrement, honorable ministre. Vous avez dépeint la situation très sérieusement. Mais je voudrais vous dire, de mon expérience, qu'en réalité, nous n'avons pas besoin de l'argent. Ce n'est pas l'argent qui est notre problème pour le secteur de la santé, non. Parce que l'argent du gouvernement, c'est pour la santé. Nous devons en réalité, et c'est pourquoi j'ai déjà écrit sur la déclaration d'Abuja qui voulait 15%. Et j'ai dit, c'est faux. On n'a pas besoin de 15%, on a 100% déjà. De quoi nous avons besoin de 15%? Non, ça ne peut pas marcher. On a 100%. Parce que la santé, qui est notre affaire maintenant, elle se trouve dans l'éducation, dans l'agriculture, dans le commerce, dans la sécurité, dans la protection de nos frontières, etc. Vous connaissez ça mieux que moi. Mais qu'est-ce que nous avons à faire des problèmes que créent les autres et à les éclater pour leur résolution? C'est ça notre problème dans le secteur de la santé. Ce n'est pas nous qui créons les problèmes de la santé. Comment voulons-nous donner la santé à une population africaine que nous connaissons à 80% analphabètes? Vous avez vu un pays dans le monde où les gens sont en bonne santé à 80% d'analphabètes? Ce n'est pas possible. Nous mettons la santé dans toutes les politiques, ce dont parle l'OMS depuis un certain temps maintenant. Adoptons, comme ça a été dit par les ministres de la Santé de l'Afrique en 2001, la promotion de la santé comme la stratégie principale d'action sur les déterminants sociaux de la santé, et nous allons avoir la santé. Nous sommes là à courir derrière les épidémies, positionnons les intrants parce que le choléra, par exemple, les autres pays n'ont pas réglé ça par le positionnement des matériaux, des intrants, non. Ils ont aménagé et amélioré les conditions de vie des gens. Vous ne donnez pas l'eau aux gens et vous dites que vous voulez lutter contre le choléra. Vous voyez, etc. Moi, je pense que nous devons revoir nos stratégies. L'argent n'est pas notre affaire. Nous avons tout ce qu'il faut. Il faut que nous sachions que la santé est à plus de 90% donnée par les autres secteurs. Si quelqu'un dit le contraire, c'est qu'il ne comprend pas la santé. Merci beaucoup.
Thank you. I would love to have this go on and on and on like you, but we will have to cap it here. I was thinking we give them each a minute, to respond quickly to this. All right, Honorable.
D'accord. Merci beaucoup. Je voudrais tout d'abord remercier Madame. Nous sommes tous conscients du défi que représente aujourd'hui le capital humain dans le système sanitaire. On peut combler rapidement le gap quand on prend les autres chapeaux, que ce soit les infrastructures, le plateau technique, renforcer la gouvernance, mais au niveau du capital humain, c'est un investissement que nous devons apporter. Et nous savons tous que l'élément central aujourd'hui, c'est le capital humain. Quand on prend ce capital humain, aussi bien en quantité qu'en qualité, tous nos pays souffrent. Parce que
Esse capital, todo o nosso país sofre.
les différents spécialistes dans tous les domaines, il n'y a pas que les médecins, même quand vous allez dans nos structures sanitaires, dans la plupart de nos pays, ceux-là, le premier maillon, qui reçoivent les patients, dont nous appelons les gardes malades ou les techniciens de surface, nous n'avons pas une école ou un module assez bien structuré pour former tout ce personnel. Donc, nous sommes très bien conscients du défi que représente ce capital humain. Et puis, chaque pays est en train de faire des efforts. Pour ce qui est de nous, notre pays, puisque je suis aussi le doyen de la faculté des sciences de la santé de l'Université de Lomé, dont j'ai aussi la charge, nous avons mis aujourd'hui en place, nous sommes en train de mettre en place un mécanisme pour pouvoir financer la formation de nos médecins spécialistes. Et maintenant, au niveau de nos systèmes, du système sanitaire, nous sommes en train de faire une réforme, ça s'appelle la réforme hospitalière, qui nous permettra de renforcer aussi la gestion en termes de ressources humaines, la gestion de ce personnel. Et puis je finirai, puisque nous avons juste quelques minutes, ce que nous sommes en train de faire aujourd'hui au Togo, c'est d'engager tous nos établissements de soins vers un projet d'établissement sur 5 ans. Cela permet de ressortir les besoins de façon globale et aussi bien cela est fait sur le plan capital humain et qui nous a permis d'ailleurs de produire un plan de renforcement du capital humain en matière de santé pour le secteur, pour notre secteur, et ce plan va être déroulé sur 5 ans. Donc, voilà un peu ce que je voudrais dire en disant que ce défi, c'est un défi pour nous et nous y travaillons et je suis certain que c'est le cas également pour les autres pays. Maintenant, pour l'intervention de notre ami, nous sommes tous conscients aujourd'hui que l'approche, quand on parle de la santé aujourd'hui, c'est une approche holistique. Ce n'est plus l'apanage exclusif des acteurs de la santé, mais c'est une affaire qui concerne tout le monde, tous les autres secteurs et tous les autres départements. L'approche, elle est holistique. Nous, pour la prise en charge des maladies non transmissibles, nous sommes allés même à l'Assemblée pour essayer de leur expliquer pour qu'on ait un financement de prise en charge des maladies non transmissibles, pour que chacun puisse comprendre qu'il doit être acteur et non uniquement l'apanage, bien sûr, je l'ai dit, du secteur de la santé. Donc, nous faisons de telle sorte que ce message puisse passer. Nous sensibilisons les uns et les autres pour que chacun puisse prendre conscience et puisse assumer sa partition parce que quand vous prenez les accidents de la voie publique, nous avons des ministères de la sécurité qui doivent aussi jouer leur rôle. Donc, c'est pour rassurer notre ami que aussi bien notre pays que les autres, nous sommes certains que cette approche holistique qui consiste à faire prendre conscience à tous les autres acteurs pour la participation, la gestion inclusive de la santé dans notre espace est bien sûr en train d'être fait et quitte à ce que cette approche soit renforcée dans les années à venir. Je vous remercie.
Thank you very much, Professor. You want to have a minute?
Sim, obrigado por não estar aqui a repetir algumas palavras e algumas contribuições avançadas pelo o ministro do Togo. E Eu acho que os intervenientes da plateia abordaram a questão de uma forma clara e corajosa. É preciso ir ver a verdade onde está e buscar as soluções. Eu costumo usar um exemplo a dizer que posso ser rico, posso ter o dinheiro para comprar, por exemplo, um carro, solicitando todas as opções possíveis. Mas se, no entanto, não tiver um bom condutor, um bom motorista, este investimento acaba por não ter a utilidade, porque não saberá usar a viatura com essas opções. É o exemplo também que eu posso trazer aqui para o pessoal da saúde. Se não capacitarmos os nossos técnicos de saúde, realmente não teremos um sistema de saúde capaz de responder às necessidades. Temos até não ter muitas infraestruturas sanitárias, mas criando outras opções, por exemplo, a criação de clínicas móveis, onde a capacitação, por exemplo, da agente da saúde comunitária, que possam nos ajudar em encontrar, identificar e localizar as necessidades de intervenção, podemos realmente não estar a fazer o entendimento. Mas há uma questão importante para que gera tudo o que nós falamos aqui para termos o sucesso, é a questão da governança. É bom não fugirmos dessa realidade, porque o sistema de saúde que não seja bem governado, que não tenha indicadores que possam avançar para a retenção, a requalificação, a capacitação e a justeza na alocação dos fundos postos à disposição, nós podemos estar a falhar. Portanto, devemos associar essas questões a essa questão da governança, que eu acho muito importante. Fico por aqui, obrigado.
Thank you. So, Honorable, you want to meeting?
Thank you very much. In my humble opinion, I think, especially with the issue of retention of health workers, is the reasons are multifaceted. It's not only one reason, in my humble opinion. Just like any worker in any country. For example, if your currency has depreciated to the extent that after getting paid, you cannot feed yourself. Hello? Hello, can you hear? Okay, so the point I'm making is that the reasons for the retention, if you like, the rate at which people are leaving, health workers are leaving to other countries, in our respective countries, in other countries are multifaceted. And the first one I mentioned is about the economy. If your currency depreciates up to a level where the health worker cannot feed himself with his entire salary, even half of the month, he or she will be willing to leave the country. And that goes beyond the health minister or even the health sector. It becomes a whole government responsibility to fix the economy. When there's hopelessness in the system, it affects almost everybody, including the health worker. For me, that is one of the factors. The second factor, if you speak to the health professional, they will tell you the person has been trained to take care of people. But in those facilities, the equipment to take care of the people are not there. And they are looking on for the people to die, whilst the person thinks that he will be able to save lives. In that case, the slightest opportunity the person gets is leaving the country. So providing the necessary equipment in the various health facilities is also another issue as government we have to deal with, and I know our respective countries are dealing with it. Again, in Africa, we have remote areas, rural areas, where most of our health workers do not like to be posted to those rural areas because of lack of basic amenities in those rural areas. Again, it goes beyond the health ministry. It's a government responsibility. Local government and other ministries come to play for us all to fix those challenges. So these are some of it. So what do we do there's the little that the health sector can do is to be able to bring out some packages. So for example, in Ghana, what we are looking at is that, you know, even internally, the distribution of medical doctors are negatively skewed towards the rural areas. About 50% of medical doctors in Ghana are in Accra, 50%. And the entire, I mean, the other 15 regions are sharing the 50%. So what we are doing is that we are putting up a package where if you're a health worker, you are set postings to the rural areas. We are thinking of giving you, addition to your salary, 20% of your basic salary, so that health workers will be willing to go to the rural areas. And we are looking at promoting them quickly than those who are in the urban cities. We are also looking at even waiving taxes on their vehicles. These are some of the packages we are thinking about so that they can remain in our country. And again, as government, I think that we need to take charge of the migration in our respective countries, because whether you like it or not, some of them will leave anyway. So as a country, what we are doing is that as government, we are rather going to facilitate the migration of these health workers whilst we make sure that we hold on to the optimal workforce we need in the country so that we don't lose them entirely. And whilst we are facilitating, we are engaging our partners to help us in the training of the health workers in our respective countries or in Ghana, so that we can train more and then we can also export more. So if we take charge of the narration or the narrative, I think that it will help all of us. But most of the challenges go beyond just the health sector of the country. Thank you.
Honorable Minister, I want to believe that we should wish you Johnny Masses now, because your flight your flight is 5. So maybe we can wish the Honorable Minister Johnny Masses. We excuse you to.
Thank you very much. Thank you. I actually apologize for that. I wish I could stay throughout, but I'm moving my budget tomorrow morning, and without my budget, I can't function for the whole year. And so I have to quickly move to Parliament tomorrow to move my budget. Thank you very much. Thank you.
Oh, okay, yes. Well, thank you very much. My comments are going to be similar. The statements by the lady and the gentleman are statements of fact, so we can only corroborate. Health workforce, in fact, is the main thing. Really, most of our challenges is workforce related. It's not really money related. Of course, workforce itself has money components to be able to train people, to be able to, it's not only just their salaries, but a lot of health workers, when you ask them, it is the little comfort they need when you post them to the village. So they have at least electricity, good housing, and they're able to take their children to school within the community. So those are the factors. Really, salary becomes secondary when you ask them. But of course, as our colleague just said, that's beyond the health sector itself. So these are all complexities of poverty. That's the bottom line. When we don't have the resources, we want to do so much, but it's not there. So how do we keep the health workers? I think we should invest in their, accommodation, give them little allowances here and there, train them, let them also see light at the end of the tunnel. Of course, without adequate resources, that becomes difficult. That is the truth. But the retention of health workers also, these factors, motivation, work environment. So it's a chicken and egg situation. Sometimes you also want to, they say they are trained, they cannot work because the equipment are not there. The equipment costs money. So you see, these are the point. You train a highly qualified radiologist. He doesn't have, or a radio oncologist. You don't have radiotherapy equipment. It's going to loiter around and eventually go. So it's a balancing act. But in Gambia, what we try to do is to actually invest in training. We told partners, World Bank is supporting our residency training program for doctors to specialize. We recruited, we have up to 100 resident doctors, more than 100 now, undergoing various training in various specialties. In 3 to 4 years, all of them would have become specialists. That's a big thing for a country like Gambia, of over 100 medical doctors specializing in other areas. We didn't stop at that. We're doing for the nurses as well, midwifery, perioperative nursing, pediatric nursing, and so on. So I think it's very strategic. So that's we told the partners that's what we wanted. We say you are buying equipment, you are building these facilities, but what about the people when they finish? And they saw sense in just what you are saying, and they are investing in that, and it's a big plus for us. And how we are doing the collaboration. Now we have up to 20 highly qualified professors and senior consultants from Ghana and Nigeria. We brought them, and they are the ones joining our people to train them. World Bank is also paying for them. So you see, we are directing the partners as to what we want, because we say you will go one day, but if we don't build capacity now, then you will leave us with the problems. So I think this is the way we guide the partners, telling them this is a country priority. Sometimes it is tough. I myself had to tell some of them that we know our problems more than you. Madam, if you want to support us, you go follow this line. The person was not happy, but eventually she became happy when they came on a visit. They realized that what we were telling them was actually the truth. I'm going to close by telling you 2 real-life stories. One of them, as my brother at the back said, when I was appointed newly Minister of Health, I sat down looking at what we inherited. It was like, this is insurmountable. How am I going to deal with this? Then I told the president, I say, Your Excellency, I think what you need to do, just let us stop dealing with the other sectors. Focus on the health sector. Let's resolve all the problems of the health sector, because it's so important. Then you can deal with the others. Leaders are interested. God gives them wisdom. Allah gives them wisdom. He smiled and said to me, Honorable Minister, but even if we buy you equipment, we build new health facilities for you, you will need electricity in your facility for your equipment to run. You will need water for your equipment. In fact, your ambulances will need roads. So he was trying to tell me, you cannot deal with one sector, leaving all the other sectors. You have to carry them along. And that is the bottom line. The second real life story, we had a US Africa Leaders Summit, I think 2023 November, and we were with the American Secretary of State. We had a roundtable, African health ministers, not the Secretary of State, Secretary for Health, a roundtable. And I said, Mr. Secretary, can we be frank? Then he said, oh, Honorable Minister, you can be frank. This is, I say, okay. I say, in fact, you are responsible for most of our problems by taking away our trained people. Then he smiled and said, Honorable Minister, I'm afraid you are saying the truth. I say, so let's look for a solution to deal with it. Then he gave me an example. He said when he was a senator in his region that was also deprived, the big corporations there, they were bringing in workers from Asia. So they were not motivated to train people from his locality. So he has to try to get something into the Senate to put forward a law that will restrict those people from doing that unconditionally. And the condition was, for any person you bring from elsewhere, you must train a local in that senatorial district. That's how he dealt with his problem. I said to him, Mr. Secretary, then reverse the thinking now. Anywhere you take a person, health worker from in Africa, train one person there. And he said that's a good thing. And we are following that up. It's slow, but I keep on following it up with his team. So that means we need to talk to partners to help us train people locally. The brain drain will not stop because greener pastures, people travel and they have the liberty to travel. But let's make sure that we train an equivalent or even a bigger number back home so that when few go, then the remaining ones stay. So these are some of the innovative things. And we believe this entity, this Africa CDC, especially our regional committee here, it's a forum to help us support each other as countries to come up with these ideas. And you know, when we come up with these ideas as a bloc, they are more likely to listen to us than when little Gambia alone says it's elsewhere. But if we say West Africa, this is our position, believe me, they'll listen to us. Thank you very much.
Okay, thank you very much, honorable ministers. Let's give them another round of applause. This has been a very interesting one. Thank you very much. Thank you. Thank you, honorable ministers. Thank you.
Thank you very much, honorable ministers, for that excellent discussion. I think the panel session was interesting, and we got some ideas, and I think we also got some way forward as to what we need to do in our countries in terms of health financing. We are almost at the end. I'm not sure. Can someone signal the director for me? Samuel, can you signal the director, RD, for me? We're about to end now, so we have 2 more items, but we'll definitely try to put them together. We will invite the Resco chair. He has already gone to give the vote of thanks. Now we have already done part of that statement, and we just go straight to the closing remarks. So we just wait for the RD, and then Minister of Health, the permanent secretary is here, or we call it Secretary General, who will give his closing remarks, followed by our Director General. And then, so we wait for the Director to come, and then we will do the closing remarks for this meeting. Peter, any? Have the Secretary General to come and give his statement, and then we will allow then the Director will come and then give the closing remarks. So, Secretary General, Dr. Kofi. Yeah.
Excellences, Messieurs les ministres de la Santé de la Gambie, du Togo, de la Guinée-Bissau et du Ghana, même s'ils viennent partir, distingués invités, mesdames et messieurs. Nous voici au terme de cette première réunion du comité régional ministériel de pilotage Resco, une étape clé dans notre engagement collectif à renforcer la coordination régionale pour une meilleure préparation et une réponse efficace aux menaces sanitaires en Afrique de l'Ouest. Je tiens à exprimer ma profonde gratitude au nom de M. Pierre Demba, ministre de la Santé, de l'Hygiène publique et de la couverture maladie universelle de Côte d'Ivoire, à chacun d'entre vous, pour votre participation active, vos contributions éclairées et votre engagement indéfectible en faveur de la sécurité sanitaire sur notre continent et particulièrement dans notre sous-région ouest africaine. Nos échanges ont été riches, porteurs de solutions et surtout révélateurs de notre volonté commune d'agir de manière concertée et efficace. Notre région, comme le reste du continent, est confrontée à des défis sanitaires majeurs Cependant, cette rencontre a démontré que nous avons la capacité et la volonté de relever ces défis ensemble. La coopération, le partage des connaissances et les soutiens mutuels sont les clés pour bâtir un système de santé résilient et réactif. Je réitère au nom de M. Pierre Demba, ministre chargé de la Santé, et au nom du gouvernement de la République de Côte d'Ivoire, notre engagement à accompagner les travaux du Resco et à œuvrer pour une Afrique de l'Ouest mieux préparée face aux crises sanitaires. J'adresse, toujours au nom du ministre de la Santé de Côte d'Ivoire, mes félicitations au président et au vice-président du Resco qui viennent d'être élus. Et je leur souhaite plein succès dans leur nouvelle mission. Avant de conclure, permettez-moi d'adresser mes vifs remerciements aux ministres de la Santé et experts présents pour leur contribution précieuse à la réussite de cette rencontre. À Africa CDC et à l'ensemble de ses partenaires techniques et financiers pour leur appui qui a permis donc cette réunion, et au comité d'organisation qui a assuré une organisation parfaite de cet événement. Mesdames et messieurs, c'est sur ces mots que je voudrais vous remercier et vous souhaiter un bon retour dans vos pays respectifs. Que Dieu garde l'Afrique et que Dieu bénisse l'Afrique de l'Ouest. Je vous remercie.
Thank Dr. Kofi, directeur de cabinet, ministère de la cabinet, ministère de la Santé de la République Côte d'Ivoire. Thank you very much. I'm learning my little French. Don't worry, you'll be my teacher. So now we will go to the last part. That will be delivered by our own director, the Director Koku, who has been instrumental in ensuring that this one-day Resco meeting is successful. He has given task to each and every one of us to ensure that we all take our responsibilities. And then based on his instruction and leadership, I think we are able to deliver the task. And we also want to thank him for the excellent leadership and coordination, because always reminding people, I hope this is done. How about this other one? So I think based on those reminders, we were able to do what is expected of us. So really thank you, Dr. Koku, for that excellent coordination of the team. Each and everyone has been given the responsibilities and we were able to do as been instructed. I also want to thank my Honorable Minister, who definitely, I'm happy to see him here together with the Permanent Secretary. They have released me to come and work for Africa CDC, and he's also one of the people who was instrumental to release me from the government to come and work for Africa CDC. I really want to thank him so much. Thank you. So on that note, I invite to Dr. Koku. Thank you.
Honorable Minister, representative from the Minister of Health, Côte d'Ivoire, partners, member states, dear colleague from Africa CDC, dear colleague from ECOWAS, ladies and gentlemen. First, allow me to thank our ministers for the sacrifice they are doing and they will be doing for us. You know, this time is a time where we should make a kind of a brainstorming about the way we are organizing ourselves to address health issue. What is going on actually with US is something that we should take seriously to rethink the way we really want to serve ourselves. So having our honorary ministers with us, and when I was listening to them, I realized that we really need to come up with our priority because we don't have resources. So how do we organize ourselves to go for evidence-based resource allocation? I hear about collaboration, and I hear about orientation. I hear about assessment, a situation assessment. And I hear about linking the priority, member state priority, to the program that are coming from partners. Those are things we should really take seriously. So I really want to thank you. Thank you, member states. Thank you, partners, ECOWAS, for being with us. My closing remark will be around 3 words. Thanks, sorry, and please. I started with the thanks. We are very grateful to see such commitment from our people. This Africa CDC is coming directly from Africa Union, and Africa Union comes from member states, which means this is our organization. And the way this is organized is not coming from us. It's coming from head of states. Head of states are the one who say that regional structure should have steering committee chaired by ministers. So they oversee everything. They make sure we are addressing their needs. They are the one who said we should have a committee that will be focusing on all technical issues. So we are just trying to follow what our head of state requests us to do. So coming up with this RETAC chair and vice chair, we just fulfill what our head of state requests from us. And I hope we will do our best. The expectation that head of states have for us and the expectation from our Minister of Health, I hope as a secretariat with the task and also the RETAC, we will do our best to make sure at least we try. We know things are hard actually with what is going on in terms of financing, but we will do our best. So thanks to everyone. I want to thank our colleague from the interpretation service. Those are part of us. We had this meeting in French, English, and Portuguese because of them. Without them, we cannot do that. So thank you so much. I'm lucky to have a big team, a very committed team in Abuja that are doing their best. for the operationalization of our regional organization. So I want to thank all of them, colleagues from Abuja, for helping us to make this. Colleague from Addis HQ, legal office, thanks for your support. So the Minister of Health specifically send people to support us as a secretariat just for this meeting. They were with us since Monday. They make sure everything goes well. Thank you for that support. It shows your commitment. Now, I want to go for the sorry. We are really sorry. Today is a holiday. And we keep you here up to 6. And we know that this period is Ramadan. And we are keeping honorable ministers here. We are making them losing the small energy that they have. So we are really sorry for this. We know in terms of logistics, from your country to the airport, from the airport to the hotel, we know the way, because of all the construction that are going, the time you spend from the airport to the hotel. We are really apologize for this. Sorry. I know when we will be back to Abidjan, in 2 or 3 months, you will see that things will change. It's a sacrifice. So the time you spend from the airport to the hotel is just in bracket for the future to be best. So sorry for this. For my colleagues, member states, partners, ECOWAS, we try to do our best. But if there is anything you feel that was not in place, please, sorry for this. Now I go for the please. Please, we have a resolution and we need to take action. Please, we listen to our ministers and we hear about what to do, how to do. So let us make sure we do our best. Let us do our part. And then in terms of emergency preparedness and response, we know the future, most of the time we don't have control on the future. Nobody imagine, before COVID, nobody planned to have quarantine, to wear masks and other things. When you take all hazard plan, no one planned for this, but it's happened. So we will do our best. We do our best by developing all our plan. We do our best by testing our plan with a simulation exercise. We do our best by putting our effort together when we come up with regional implementation, not just focus on member states. We do our best when we have coordination in terms of cross-border surveillance. Actually, we have Mpox, we have cholera, and we also have Lassa fever. And this is endemic in our region. Let us work together. And we said this, and we will be saying this. Outbreak doesn't have a border. So there is no Burkina Faso, there is no Togo, there is no Nigeria, there is no Gambia for Lassa fever. It goes everywhere. So let us focus on our West Africa and try to bring everyone on board so we can reach that target, the 717, and also the 0 dose that we have actually. Let us work together. With this expectation, honorable ministers, allow me once again to thank you and to end this meeting. And I hope for those who will stay up to tomorrow, today's holidays, We know we are in Ramadan, but this doesn't stop us to move around, to have a kind of Abidjan by night, get to see things that we can bring souvenir to our country, so people know that we are coming from Akwaba countries. Thank you so much.
So we can now network, we can communicate, we can exchange contacts. So that's the end of it. So we can now prepare. Those who are fasting, you can get your coupons from the food, the restaurant. You got your coupon? Yes. Yeah. So get your coupons and get ready for the lunch. And those who have not cleared your DSS, you can kindly work out the forms and then send it to the accountant before they go. Thank you very much. See you another time. Thank you.